All right, well, welcome everyone. Thank you so much for being here. We're so glad each of you is here. Are you hearing feedback? Can you turn off the podium? Okay, thank you. Thanks for your patience with us. I am Lily Catalano. I am a social worker and I work at the National Healthcare for the Homeless Council. This session today is a collaboration between the Council and the Homeless and Housing Resource Center, HHRC. They have been fantastic partners, and we're so excited for this opportunity to work together and share this learning lab with you all today. Jen is going to tell you a little bit more about the work they do in a few minutes, but I highly encourage you to check out their online resource hub that has free trainings about homelessness and health and housing. Our topic today is suicide prevention. So likely most all of us have been impacted by suicide in our work, in our families, in our communities, or suicidality in ourselves. It can be heavy, it can be painful. We can each have different ways of responding to that. Just the word suicide can bring up a physical response, and we might feel fear or grief or overwhelmed. Those are natural human responses, and we don't have to fight them. That's okay. Part of what we might look to do today is notice what's coming up for us throughout the day and find ways of taking action that lines up with our values and can be helpful to the folks we're engaging with. So I encourage you to notice your feelings and your thoughts and your reactions throughout the day and do whatever is helpful to you. That might include stepping out, that might include a one-on-one conversation with someone you meet in here or I'm happy to have a one-on-one conversation anytime today. On your table there are fidget toys, there are coloring pages, there are breathing tools that we're going to use in a second. Please make use of any of those that might be helpful to you. Working with someone who is contemplating suicide and being there with them in an extremely painful time can be very meaningful, and it can also take a toll. So part of the beauty of being in a community, which might be the team that you work in, means that we can share in that, and we can step up and we can step back as we need to. So part of what we'll be talking about today is what we can do in order to hold space for conversations about suicide. And that includes self-care, but it's also not just on individuals. We'll talk about how teams and organizations and communities can offer support too. So I also want to acknowledge that different cultures, different individuals have different perspectives on suicide, including different views on personal autonomy and the ethics of suicide in different situations. Our session today is not focused on those conversations, but they're really important. And the council regularly has community conversations where we explore some of the ethics and the nuances of these complex topics. So I highly encourage you to join us for future convenings to explore these topics if that's something that's of interest to you. So we're going to start this morning with a couple brief grounding exercises. First, I invite you to try some muscle relaxation, and you can choose any body area you like. You might consider your hands or your feet or your shoulders or your calves or your face, anything you'd like. And then for the area of the body that you choose, we're going to tense our muscles tightly, but not to the point of strain. Hold the tension for 10 seconds and pay close attention to how it feels. Now release the tension and notice the feeling of relaxation and how that might be different from the feeling of tension. That's something you can go back to today at any time with it. You could try a different part of your body, or if there's a place that you are feeling tension, you could go there with more focus and then release. We'll also do a few minutes of deep breathing. On your table, there's a squiggly square tool that can be helpful for giving you a physical action to do as you count your breath. But I invite you to sit comfortably, breathe in deeply for a count of 4, 2, 3, 4. Pause for a count of 3, 4. Exhale, 2, 3, 4. And pause, 2, 3, 4. We can do that again. Inhale, 2, 3, 4. Pause, 2, 3, 4. Exhale, 2, 3, 4. Pause, 2, 3, 4. So these grounding exercises and others that you may use all the time are here for you anytime today. We are scheduled to end at 12:30 today. We'll take a break at 10:30. Also on your table there are, like I said, fidgets and different items. Make use of those as you like. There's also a worksheet on your table to take notes of key takeaways and next steps. Our final part of the morning together today will be to work on that and discuss a bit together, but if you want to take any notes as we go, it's divided by the different sections of our workshop today. So feel free to write down anything that strikes you as something you want to be sure to take away with you. All right, I will pass it over to Jen Elder.
Thanks, Lily. Hi, good morning. Well, you can tell it's day 3. Good morning. We'll get there. I feel like I'm already hoarse from 3 days of meeting people, talking to people, being excited to be around friends and colleagues again. I don't know if others have. Is this your first conference? Oh, a lot of you, it's your first conference. Okay, yeah, well, that's wonderful. So I hope to see you all next year because it starts to be like this wonderful, very healing reunion of colleagues all getting together, very passionate about the same things. So as Lily said, I'm Jen Elder. My pronouns are she, her, and I'm the director of SAMHSA's Homeless and Housing Resource Center. And so we are collaborating on this workshop. Because I'm SAMHSA, I do have to have a disclaimer. I'm funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions I express today aren't necessarily SAMHSA or the Department of Health and Human Services. And I'm only talking about 10 minutes, so I might not go off the rails, but we have been disclaimed in case I say anything the administration would not be proud of. So just quickly, my job today is really to frame the session, to give us a roadmap for where we're going, and then to hand it over to amazing speakers. Bridie's there, Lawanda and Lynea, and Lily's going to be sharing some too. Just a lot of great tools, a lot of great discussion today. So our partnership with the council, we've been partners for years. How this came about is we heard from you, what you were needing in the field. You were needing and wanting more resources and a space for discussion about coping with grief and loss and tools, because that is something we're increasingly facing. I do hope that you'll check out HHRC and the resources we have. We have a lot of great free online training courses and trauma-informed practices. So if you have new staff, if you are new staff yourself, they're accredited by the National Association of Social Workers for free CEUs, so that can also be a good incentive. But I invite you to join us as we kind of continue this journey. We also soon, maybe in a couple months or sooner, have an online course coming out that we've been working with the council on around methamphetamine use and supports in housing. So I'm very excited about that. So I hope that you'll join us. All right, so where are we going today? What does today's roadmap look like? Just starting by framing, we know that deaths by suicide are rising for some groups more than others. And the impact on all of our collective work can be profoundly traumatic. We work in a really heavy field and heavy topics with hard things. And so recognizing that, but then where do we go with that? How do we help our teams? How do we help ourselves and each other cope with that? So it is my wish and hope today that we also leave with a very hopeful message and feeling empowered to go put some of these ideas into practice in your communities. So I'm not going to linger on the stats part of the framework. I was kind of thinking about, like, what should I even talk about here. Usually I give these talks to governors and mayors as a different part of my SAMHSA work, and because I'm like trying to get them to care about suicide among people experiencing homelessness, specifically veterans is what I work on there. And so it's like really stat heavy presentations, but you already know a lot of this because you see it. You see it in your health centers, you see it in your communities. But just kind of grounding us today is we do know that suicidal ideation and attempts are much higher for the populations that we serve. There were some really good reviews of studies recently. Suicidal ideation currently almost a fifth of the people experiencing homelessness, lifetime 42%. For veterans experiencing homelessness, the lifetime prevalence was as high as 74% for suicidal ideation, which is a really concerning figure for me. Suicide attempts also much higher than the general population, 9% recently, and 29% for over the course of the lifetime. It was really interesting, as you know, the mortality data, so I really focused on ideation and attempts because the mortality data is incomplete, and so there's a lot that we don't know about deaths by suicide, but you know a lot in your communities for what you're seeing. So plug to, if you are seeing that and studying that and tracking that, join the council's mortality working group because they're doing just amazing work in trying to come up with a better, more complete national picture of what we're seeing. So one thing I wanted to focus on today too is the disparities and the intersectionalities. We know we all have varying identities, and so some groups are disproportionately affected than others. So suicide did increase almost 60% in 10 to 24-year-olds over a 10-year period. But within that, and there was not enough slides or enough room for words on slides to go into all of the details, but just to get you thinking, like, that's not enough just to say, okay, children and youth, it's rising. There are, within that, disparities for race. Black youth are more at risk than their white counterparts. Sexual orientation, LGBTQ youth, more at risk for suicide, gender identity. So all of that comes into play, and it's just like this very, complex onion when we think about it. I did, of course, want to recognize that transgender individuals, 40% have attempted suicide in their lifetime, which is very concerning to me. I am in Missouri, so we are not having very good laws right now, as I know many of you are, and I think these laws, they have like life-affecting consequences, and so we need to be, telling our congressmen and our leaders about this, so kind of helping raise awareness of this. Suicide risk does increase in American Indian, Alaska Native populations, far exceeds the general population, but kind of extra concerningly is the rise over a 10-year period for females. It rose 140%. So again, we're seeing disproportionalities and disparities within that group. Other factors, veteran status, rural geography, disabling conditions, also increases the risk of suicide. So with that, you can probably, even for yourselves, pick out varying identities within this group that you have of intersectionalities, of people you serve. And so just kind of increasing that awareness of the risk factors, they do compound. The impact on the care teams, that's really a lot of the nuts and bolts of what we're going to talk about for the next 3.5 hours today. I think it's going to go by really fast though. This is profoundly traumatic for care teams. And when I say care teams, I want you to take a really wide angle lens about that, because it's not just the clinician who sees them, the therapist, the doctor. It's the front desk staff who checks somebody in and asks them how their day is and helps them get a cup of coffee and sees them repeatedly, engages with them. I see them as a wider member of the care team. It's anybody who's interacting with people that your program is serving. It's really common to have guilt and blame, and that translates into self-doubt about their professional judgment. And we know that we're having really good providers leave the field because this is hard. And so trying to mitigate this, one, can help our overall well-being, but help keep the good providers in the field doing this very, very hard work. So it's kind of the opportunities to moderate the impact, I think is really setting up the rest of the day, talking about informal peer support, approaches that avoid blame-seeking, and more training about this is a possibility. We see the stats. We know that we're going to come in contact with somebody who is thinking about suicide or has attempted suicide. So how do we provide the best care, both to the people we're serving and for ourselves? So here's where I get to leave you with questions and then turn it over to the rest of the presenters for today. So things that I would love for you to think about as you go into the rest of the session and think about your action planning is what is this looking like in your community, in your clinic, or in your team? What intersectionalities exist, both in the patients and the populations you're serving, but also in your care team? Because our identities affect the way we show up to work. They affect the way we do our jobs. They should. We bring ourselves into this work. So what does that look like on your team? And where are there opportunities? So how comfortable are your staff in talking about suicide and connecting people to resources? Is more training needed? We'll have a great section on that. How is information about deaths by suicide communicated? Do you have a trauma-informed communication strategy? How do people know? Because that's critical to know how to how that's disseminated to your teams, and what support is in place for processing grief and trauma. So those are things we're going to get into way more depth in today, but just would encourage you again to use the resources at the table. Talk to us if you, as you need to, talk to each other, learn from each other today. That's what's so amazing about a learning lab, is not just learning from us, it's learning from each other, because you all have great best practices. So with that, if anybody wants the references, it's all on the slide deck. I will turn it back over to Lily.
Thank you, Jen. And all the slides are also in the app, so if as well as the handouts that are on your table. So you're welcome to follow along there, or if you want to share with anyone back at your organization, please feel free. As Jen said, part of what we're going to be doing later today is talking about rituals for honoring those who we have lost and reflecting on our experience. We're also going to have space for that to happen in this room today, if that feels helpful to anyone. If there are people that you are thinking about through the day, remembering, I invite you to use one of the colored papers on your table. You can write a name or a symbol or anything that you would like to put down on paper. And we have some white papers in the back of the room, and you're welcome to just post anything there that comes up for you that you would like. So that's available throughout the day. We're also just going to pause for a moment before we move into the specifics about talking about suicide. You can use this minute to take some deep breaths, to think about anyone who's on your mind. We'll just spend a moment in quiet. Thank you. And Lynea is now going to lead us into the next section of the presentation. Oops.
Yeah. Hello, everyone. Thank you for being here. My name is Lynea Seiberlich-Wheeler. I'm a licensed clinical social worker out in California, and I am going to talk us through how to have conversations about suicide. I feel like this is where a lot of us get held up. in this process. We care, and we don't know how to talk about it. I'm going to be using tools and information that are nationally recognized tools, and then also tools that are specific to where I'm physically located, which is in Sonoma County, California. And some of these tools may be useful in your area, or they may need some adaptation, and you're welcome to use whatever feels useful to you. And they're all uploaded onto the app as well. And there's a couple of tools that are on the tables that I'll talk through as well. And, oh, my pronouns, she and her. I have my notes in case I forget things like that. The tools that I'm providing are meant to be easy to access. I don't know about you guys, but we have a ton of turnover all the time in this work because it's so hard, and because people are coming in new in their career and then discover what they want to do and then go off to do even greater things. And so these are things that I found to be fairly easy to train on. So you can get the hang of it, your colleagues can get the hang of it, your friends can get the hang of it, and it can help keep the conversation about suicide going in your context. They're also all either evidence-based or socially promoted by reputable sources. So if you are in a context that has to worry about things like audits, which I am, these are all audit-approved resources as well. All right, so let's talk about setting the tone. When we enter, so I'm a licensed clinical social worker, I'm a therapist, I supervise therapists, and so I have training in terms of entering a conversation with somebody, regardless of what we're going to talk about. And that kind of training has been really helpful for talking about suicide. So I'm going to give you some tips. One, the primary thing is to just exude, I am a safe person to talk to right now. You can talk to me about this. I'm the one, I'm right here, you can tell me things. And it's okay. It's okay to tell me things. That's the primary thing. You may not know what the heck you're doing. You may not know what to do next. You may not want to hear what you're about to hear. And yet the person sitting with you is going to know from your body language, from your tone, that like you're here. I'm a safe person to talk to. And also, in addition to that, be aware of where you are. Be aware of your context. A lot of changes have happened for the better in my community, but it used to be, and it may still be in areas where you are, that emergency response to a mental health emergency led to death. And so it's important to know that if you live in a place where if you call law enforcement to help out with a mental health emergency, that they're going to come in guns a-blazing and save the day in differently than what you were hoping for. You're going to want to know that ahead of time so that you can understand what's the actual best next step to take. This can come up a lot when there's a lot of prejudice in the area, whether it be racism or prejudice against gender expansiveness or just difference in general or misunderstandings about mental health. There's a lot of extra work. It's a whole nother talk about how to fix all those things. They can change. Some of this has changed where I work. But know where you are. Know where you are so that you can make decisions with the person in front of you that actually make the most sense in terms of addressing the topic of suicide. It's also important to remember that when we're talking to someone about suicide, the end goal may not be to help that person feel better. It may actually be quite appropriate for that person to feel really, really bad. Something terrible may have happened, and it's important to validate what feels important to the person that you're talking to. There may be some community shared burdens or ancestral burdens that are really important for that person to carry forward. And so in talking about suicide, it may not be the end game of relief. It may be connection to life. How do we carry these burdens forward with honor and with respect and with whatever is pulling them forward? And that's not to say that it can't be to feel better. For some people, that is appropriate. So just to acknowledge that when you're going into the conversation, it's about connection to life, whatever that looks like for the person that you're talking to. Another thing that I wanted to make note of is that we are wired to survive. You may have been in conversations before about fight or flight responses. The reason why we have these instincts is because our bodies are built to survive. We have this innate ability to recognize danger and to act without even thinking. And so there's a lot of fear that can happen. If I talk about suicide, if I bring it up, I'm going to create suicide. And because we have the innate need to survive, it's just not true. If somebody tells us that they're having thoughts about ending their own life or wanting to die, that didn't have anything to do with me. I mean, I could have. Maybe I did something terrible, but not likely. Likely it's a package thing. There's a lot going on. And we also have this innate ability to heal, which means that there's treatment that works. So if we find out that somebody is having these thoughts or these worries, or they think that suicide may be the answer, the best answer to their current problems or situation, there's actually something we can do about that that works, that will help find a different alternative path to whatever healing or moving forward feels best to that person. So I want to set up like that because particularly around, last week, I was talking to some colleagues about electronic medical record buttons and who gets to ask the suicide question on the PHQ-9, which some of you may be familiar with. It's a depression screening that's used in a lot of places. And the person who's in charge of clicking the buttons in the medical record said to me, "But we don't want to ask because then they're going to want to do it." And I was like, "Oh, I've worked here for a really long time, and I'm really surprised that you said that to me. And that we haven't had this conversation before." I'm so glad that you spoke up because let me tell you, if you ask the question, you're going to find out what people are thinking about. You're not going to put the idea in somebody's head. It's quite different than like, "Hey, do you feel like having ice cream?" Actually, that does sound good. I wasn't thinking about it before, but now I really want ice cream. Suicide is different because of that innate need to survive. And emotions can really build up in us, and it creates a lot of pressure. And if we can identify what is that pressure point, which suicide and thinking about ending our lives may be a part of that buildup, if we talk about it, then we can resume the flow of emotions, and we can have more of a conversation about other things in addition to that intense feeling. Okay, so let's talk a little bit about, what do I say? This is on the left side, this is something I copied and pasted from SAMHSA's website. So I've got links on the end of this slide deck too for all of the resources. But this is available to everybody. Everybody in the whole world can get to this right here. And one of the things that I like about this is that it breaks things down pretty simply. Do this, do this, do this, do this. And when you're having this conversation with folks, you really want to take them seriously. I work with a lot of folks who at times are really dramatic And I can understand in their context that they need something, and it may have nothing to do with ending their life, but that's the drama of the moment. I'm gonna die. This is my last moment. You're never gonna see me again. And even if I know that that's not really what they wanna do, I'm still gonna take them really serious, because people who are being really dramatic sometimes take really dramatic actions. Even if the end result wasn't what they were needing, maybe they needed something else, and they're just really bad at getting it right now, I'm going to take them seriously, because we got to get through that piece of drama in order to start doing some other work, so that they have other ways to ask for their needs. So I'm going to take them seriously every time, even if it's the 15 millionth time that they've told me this really dramatically. I'm going to be like, I take you seriously. So firstly, I'm going to identify risk factors, and risk factors to me are really straightforward. In therapy, risk factors are giant. There's like so many things. When I'm talking about suicide or ending someone wanting to end their life, I can just really dig in, and we're going to look at a tool that gives a list of some of the questions. I'm going to know, how seriously are you thinking about this? Like, do you really want to do this? You're thinking about it, but do you want to do it? Have you been thinking about how you're going to do it? Like, how far has it gone? Like, do you have a plan? Okay, well, do you think you're going to do the plan? Are you going to do it? Okay, when? All right, I want give me the scoop, give me the tea. I want to know everything, okay? The who, what, where, when, how, and why. And has this ever happened before? Did you do this? Is this something that you've thought about before? Have you tried this before? That's what I want to know. Those are the risks. Like, how far has these thoughts gone? And then I'm going to talk about protective factors, which is a fancy term for what keeps you living. Who do you live with? Do you have any pets? Do you have any friends? Do you have something you like to do? What's going on in your life that has kept you alive so far? And is there any of those things that you care about in this moment? Sometimes when we go into a headspace where we're feeling really depressed, we actually lose memory of those connections. They're there. Like, I might have people who really care about me, and I know it. But when I'm in this different headspace, I actually can't remember that that's true. And so sometimes talking it through can help to jog the memory. Who's there? And so getting some information about what are the current connections to life in this moment. And then we've got, it says conduct suicide inquiry, which I do first. I'm like, just tell me all the things, let's just get into it. And then determine the risk level, which we already did. And then document is last. My least favorite part of my job. I spend like 50% of my life documenting, writing down what I do, and I do not like it. It feels so silly to like go out and do these important things and then have to sit at a desk and then write it all down. However, I have found that this piece tends to be really essential. The part of the essentialness that I like and that I buy into is that I am not the only one on this person's team or in this person's community. And if I can write down everything that happened, then other people on the team can more easily be up to speed and continue the progress forward, or fill in the gaps, or make some new suggestions, maybe take us in an even better direction. That's the part of documentation that I buy into. The part that frustrates me, but it's a reality, and so I guess I sort of buy into it because I like getting paid for my work, is that the people who pay us only believe that we did something if we write it down. And so a lot of the tools that we're talking about today are specifically created to meet documentation requirements. And although they're evidence-based, which means that they work, the way that they're intended to work in real life. We don't want them to be the drivers of the conversation. We want them to be a reflective of the conversation. We're going to use them today as training tools, but I want to just keep that out there, that sometimes the documents are not for the conversation, they're for getting paid for the conversation and or saving our butts in case something goes wrong. And where I work in 2021, we did have an audit from our version of Medicaid. We call Medi-Cal, and then there's a managed care plan that has a different name, and then there's a subcontract with a different company, all the things. We had a patient die by suicide, and anytime that happens, we have to call the insurance company, whoever it happens to be, and inform them. And then they did an audit, and it was a really awful experience because they came in saying, "Why did you do this?" As though we had done something, which we didn't do the suicide. And that was sort of the tone of the conversation. Why did you do this? And we actually didn't have all of the things documented that we had done, which made it really hard to have these conversations of, we actually were doing all of these really important things and it didn't end up working. And that's the kind of conversation that we would rather have had instead of trying to defend ourselves. And so having the documentation can really help in unfortunate situations like that. And one of my colleagues here, Bridie, is going to talk more about what that's like for us as folks who lose people, and go into more about handling that. But write everything down. Write everything down. So then we've got this tool is the Columbia screen. And this is a tool that's available in a bunch of different languages and has some training tools attached to it on their website, which is on the last slide of my slide deck. One of the things that I like about this tool is it says all of those questions that I mentioned about how far is this thought gone? Are you just thinking about it, or are you going to do it? And how likely is it that you're going to do it? And although it's not pretty, they don't have the graphic designers of the century, they've got these little red and yellow indicators to say this is very bad versus this is not as bad versus we're pretty safe here. And that's helpful for training, right? I just want to know, how serious is this? I might be freaked out having this conversation with somebody. This paper's going to help me remember this is very bad, this is not as bad. And it is true that sometimes people are thinking about suicide and they aren't going to do it. They're not going to try suicide, and they're not going to die by suicide. And so this helps us to know the difference, too, so that we can respond appropriately. And you have a copy of this on your tables as well. And one of the things that I want to sort of reiterate is that when somebody is thinking about suicide, it's not our fault that that's happening. We didn't do that. It is our responsibility as a member of this person's community or this person's care team to know how they're doing. And so this is a tool that can be used to document the conversation that we're having to say, hey, how are you doing? This person that I care about, whether I care about you because it's my job to care about you, or I care about you because I actually care about you, because you're in my life. When to use this tool, this is not the first thing that you say to somebody when you meet them. Are you thinking about dying today? This is a tool that you use when it comes up. when somebody tells you. If you're in a clinic setting, which is where I'm at, then we ask a lot. We have requirements to ask a lot about how people are doing. The PHQ-9 that I mentioned is a very common screening tool for depression, where we're like, how are you sleeping? How are you eating? Do you feel bad? And there's a question on there that says something to the effect of, have you been thinking about how you don't want to wake up in the morning, or that it's better, you're better off dead? And if someone is like, yes, I have been thinking about that, then we follow up with these deeper questions. But there's no need to overreact, right? If somebody's like, I feel like crap, my life is terrible, I feel hopeless, I feel helpless, but no, I'm not really thinking about dying, then we don't have to go into all of this extra stuff. This is for when it's actually the topic of conversation. And then we're going to go to protective factors. And I couldn't find a tool for this, which is, my hunch is that's because when you get an audit done, they're not like, well, did you ask about the protective factors? They ask about, exactly. Let's create some change here. Let's focus on what's actually going to drive healing. The Columbia screen was created because we're always asked to prove that we had these conversations about whether or not someone's going to die, but we're not asked to prove that we asked whether or not somebody is going to live. So that's my hunch. Don't quote me on it, because probably other people have different opinions. And so this is another, I didn't exactly copy and paste it, but I did write it verbatim from a tool in SAMHSA as well. And no, this one's not from SAMHSA. This one's from the Center for Disease Control. And the link is also in the resource list. And I feel like this is a pretty good list of things to ask about in terms of protective factors. Like, okay, you want to die, and you're kind of serious about it. What else is going on? And here's a nice little list of things that could save the day, could help somebody get through this moment. Feelings pass, thoughts pass. Thoughts about suicide are going to pass. These are the types of things that help people get over that hump to the other side. And a lot of times I ask people, well, what has kept you living this far? Like, what is it? How have you made it? Things are really bad. Obviously, you feel so badly. What has worked? And then people will tell me, and then they're usually something that's on this list. A lot of people love their pets and would never abandon their pets. Thank goodness for pets. And there may be other things too. Religion's another big one that I see. People are like, I could, like God says no, and I'm going to do everything that God says. And I'm like, great, let's do that. And there might be something else too, like I really actually love volunteering at this place. Or, when I show up to go get my shower, these people are really nice to me. Like, a lot of times there's something and then the connection is just lost. So here's a nice list that can be used to help recognize what is keeping people alive and where are the opportunities to build. And so then what do we do? And I'm going to be talking about what do I do in the moment in the conversation. And my colleague Lawanda is going to be talking more about some of these things in terms of treatment. But we're going to be looking at immediate safety. Like, do I have to save your life right now? Because it's my job. My literal job is to save people's lives. I'm required to do it. Not everybody has that as a part of their job. But I'm looking at immediate safety. Do I need to respond in some way to keep you alive right now? And then also I've got to think about mandated reporting. And also I put peers here, although I'm recognizing that peers actually go to the top. And I'll talk more about that. So safety planning has to do with immediate safety. What's the plan right now to keep you safe. And there is a handout on your tables as well that sort of walks you through the conversation for safety planning. It has a list of all of these types of questions. So asking the person, how do you know that things are this bad? Like, how did you know that it was bad enough that you wanted to die? And then also, like, what's worked for you? When we asked for the protective factors, we kind of find out, like, well, what has been working for you? What helps you to get through these things? What's helped you in the past? Who can you call? Who do you trust? And that could be friends, family. A lot of times it's professionals for the folks that I work with. They come in, they talk to me, and they're like, you're the reason why I'm still alive. And I think that is a lot of pressure, and I'm gonna mess this up. And at the same time, the clinic staff are the healthiest relationships that this person has access to. And so I really get that, and I can lean into that, and I can say, I'm so glad you came, because I'm really glad that you're in my life too. And then there's also making the environment safe. And that has to do with if somebody has a specific plan to use a specific item or tool or method for ending their life, how can we create some space between you and that thing, whatever it is? And that can take a lot of creativity. Like, do you have a friend who can hold that for you? Or can you bury it in your backyard or wherever your encampment is just for a few days? Do you want to leave it here and then come back tomorrow and then we can talk more? Sometimes that can take some creativity, and it's an important part of the process, how to create some space between the person and the method. And then there's some app examples. Because some people have phones that they like using, and there's an app for that. And so there needs to be more. These are literally the ones that I found that I thought were decent. And that's a way that people can sort of write down and have a handheld reminder. And there's also a fillable PDF of a safety plan example that goes along with what I've handed out here that's attached, that we use where I work to document the conversation. I have not found the document to be that useful to like sit and write it down with the folks that I work with. It's just not the style of sort of connection that works for them, but it is a really great documentation tool, and we made it easy for y'all. You could just type, upload, print, whatever you want to do with it. So that's available for everybody. And then I want to talk a little bit about mandated reporting, because sometimes we're required to engage emergency services, even if we're in a place where emergency services are more dangerous than the person's desire to die. And it's important to know if that's your job. It's not everybody's job, but it is mine. And in California, we've got a list, which I put the link in here, for California, that tells you if your role is a mandated reporter. Are you mandated to call an outside authority to help intervene? And suicide is a situation where I'm mandated to report it because I'm required to save the person's life, is what the intention is behind that. And we have had, where I live and work in Sonoma County, in the past, there were deaths by law enforcement who were responding to mental health emergencies. And what we learned was happening is that we would call really freaked out and be like, oh my gosh, this danger is happening, please come help. And law enforcement would show up ready to save the callers, protect the caller from danger, is really what the perspective was. I'm gonna protect you from danger. So they would come in, and then they would respond in a way that was intended to protect the caller, not to assess the situation and de-escalate, and people died. And I won't go into details because y'all have good imaginations and probably real life experiences that you can rely on for that. And so our county behavioral health department and a local nonprofit, a behavioral health nonprofit, worked together to put a script together for engaging law enforcement or engaging emergency services, what we call 911. And that actually really changed what was happening when people responded, when law enforcement responded to mental health emergencies. Some additional services have been tacked onto that, but we still have to engage law enforcement first before other additional things sort of get scooped in mental health wise. And the change was that now when I call, I'm like, hi friend, I have this other friend who's having a mental health problem, and I think they're trying to kill themselves, and could you please go check on them? And then what happens is they're like, oh, I'm gonna go check on my friend. It was really interesting to learn. I don't know why I didn't know this ahead of time, but law enforcement humans are humans. And when you call them for help, they're emotionally connecting to you. So I'm like calling the dispatcher freaked out. The dispatcher is like it's an emergency, police officer, go, go, go. And then they go and they're ready with the best tool that they are trained with, which is not mental health based. And then terrible things happen. And so now when I call, I'm like, hi, I'm your neighbor, Lynea, at the clinic. I've got a person that that needs some help. And so I've got this is the suicide and overdose attempt script, and there's other scripts too. There's one for this person has a weapon. That's been really helpful. Because weapons add an extra level of I'm freaked outedness, even to law enforcement who carry weapons. They also have feelings. And the links to this is also in the slide too. And one of the things that I've noted, this has been around now for maybe 10-ish years, maybe a little less than that. And there's a couple things that I don't actually do. I don't give the diagnosis, the mental health diagnosis. I just don't. I'm just like, they've got some mental health problems, and that's enough. Because there's a lot of misunderstanding about some diagnoses, like say schizophrenia, and they think totally wigged out, and that might not actually be the case. Maybe some other things going on. So I'm like, they have a mental health condition. That's enough. And then I do, if there's other health issues that are relevant, like they've got a pacemaker, or they're on dialysis, or they just got checked out for lung cancer, things that are kind of helpful for law enforcement to know that if you shove this person around, they might die. Don't do that. And so that helps. And then they also can be thinking, do I also have to call in an ambulance? When the law enforcement arrives first, they can also be sussing out whether or not this is also a medical emergency. And that's been really helpful. It's like I'm able, with this simple script, to give tools to law enforcement that they didn't have previously. And it has also changed some of the conversation with law enforcement so that over time, did take 10 years, in the last year or so, we've started to model outreach teams based upon other states' models where mental health workers and law enforcement are buddied up. When they're responding to calls, and that's newer. So there we go. So peers. Why didn't I talk about peers first? No good reason. One of the things that I think that is important to recognize is that professionals, mental health workers, are often put in the situation where everybody's referred to us as though we're the ones who have this magic answer about how to talk about suicide, how to fix it, knows exactly what to do. And really, the conversation about suicide is something that we should all be having. Not all the time, you're out to lunch with your friends and have you thought about suicide lately? Like, that's really random and unnecessary. But what is necessary is to connect with the people in our lives and be saying, oh, how are you? And sort of celebrate joys and sort of be sad together and know, how are we doing? How are we doing? And this is a part of that conversation. It can come up. And we can know that even if we're really freaked out about it, we can actually have this conversation. And there's something that can be done about it. I might not know what to do, but I can sit with you while we figure it out. And I can ask you again tomorrow, like, how are you today? And if I'm overwhelmed and I just can't, like I've reached my capacity of compassion for the day or whatever, I can still say I care about you. And I can say, let's loop in some other people as well. So I don't have to be like the one and only savior of the moment. And when I talk to people in my work, very frequently, people tell me at the end of our conversation that they feel better. And I'm always like, oh, that was lucky. I don't know. And so it's really about the human connection. And that's why peers kind of goes in the top of the list, because we have now more and more peer roles on our teams. And yet, when we're having this conversation, we all need to be peers. We need to be a human talking to a human. We need to be able to talk about this kind of stuff to our friends, to our family, out in the world. How are you doing? Are you okay? I'm so glad you're okay. Oh, I'm so sorry that you're not okay. Do you want to tell me about it? You know, like connection. And another thing to note is peers are way more effective at sort of building and strengthening protective factors than other folks. Me as a therapist, I'm somewhat confined by the 50-minute space that I have, and we can go through the things, and I'm like, okay, we've got a great plan. See you next week, maybe. And a peer has a different role and a different approach where you can be buddies, you can link arms, and you can say, okay, well, let's do this next step together. Let's just do it, whatever it is. And there's also a different perspective where me as a therapist being trained, I'm trained to kind of be an other. I'm trained to like sit in a taller chair and look at the whole scene and figure things out and make assessments and then hand over a platter of solutions. That's kind of how I'm trained. I'm trying to untrain myself in that way to be more in like the same size chair and have it be more of a back and forth. And peers opposite are folks who are recognized for being with other people. And when you're with other people and you've walked through your own life, which we all have, then you can take somebody with you on their journey as well. All right. Where are we at? Okay, we're at practice. So, the best way to feel comfortable having this conversation is to already have had this conversation. And so we're going to try that today. And you have on your tables the Columbia screen and a safety planning tool. And what I'd like you to do is to, in groups of 2 or 3, say these questions out loud. And I'm going to give about 5 minutes, and then I'll have a switch, and then I'll have a switch again, and then we'll come back together. But really just give yourself a chance to say the words out loud, meaningful or not. Having said it before makes it way easier to say it again when you're in a situation where it may be more helpful. So let's have the conversation. All right, I'm going to go ahead and grab everybody's attention back. Hi, everyone. I'm so glad you're having this conversation, and this is not the end, right? This is the beginning of a long conversation. Thank you, Bridie. I'm so glad that you all are engaging. Anybody, I've got time for a couple of comments or questions before I pass it to Lawanda to talk more about treatment, but how was it? It was good? Comfortable from someone? Yeah.
Yeah, we were talking a lot about contacting people to whether you're using a standard setting or someone calls you over the phone, you're having a crisis moment, how to utilize these questions in different settings.
Yeah, great. A conversation, just to repeat it for the group, conversation about when to use it, whether it's in person or on the phone. And then were you going to say more?
Yeah, one other thing, I know this will come up later, but it's about asking the questions around suicide itself, and phrasing it. And I've heard a lot, you ask folks use, are you feeling safe? Or do you have plans to hurt yourself? And knowing that those questions are not asking about suicide.
I love that comment. So he's taking note. What's your name? Will. Will is taking note that sometimes people ask, are you feeling safe or are you going to hurt yourself, which is actually not the same as asking if someone is going to try to end their life, if they're going to try suicide. So it is very helpful to specifically ask about suicide. Yeah.
My name is Regina, and Melissa brought up a very good point about suicide screening, that she used it often at the VA. And she said that once she completes this, if they answer questions that are going into the hybrid answer, then she goes to the C and E screening. So I thought that was good to know.
Thank you, Regina. Yes, so speaking to an additional next step tool, the CRE screening, which I didn't even present on, so you could know that this is not the end of the conversation, right? Thank you, Regina. One more, I've got time for one more comment. Yeah. Yeah, great. Thank you. What's your name? Alicia. Thank you, Alicia. So Alicia is talking about how on at least one example, probably not the only one example, that there's the one person that gets to talk to you about suicide. And so everybody's like, bring her in. And then you walk in and then the consumer is like, oh, okay, thanks. And that happens, especially medical providers. They've got like 30 seconds or less to solve 50 problems. And so they're like, who can I delegate to? And really, and I do trainings with the medical providers I work with too. This is our conversation. It's our responsibility to take the moment, to put everything else aside. This becomes the most important conversation of the moment. Perhaps there won't be time for everything else, and that is okay because we're going to give you a chance to have a different option than this option. Thank you. Thank you for all of your comments, and I'm going to pass it to Lawanda, who's going to talk more about what do we do?
Yeah. Great. Do you want to take it from there? Yeah. Okay. I don't think so. Let's see. Oh. All right. Hi, everybody. Hello there. My name is Lawanda Williams, and I am a native here in Baltimore. I work at Healthcare for the Homeless right down the road, and I'm a licensed clinical social worker, and I have the privilege of serving as a Chief Behavioral Health Officer at Healthcare for the Homeless. So I'm very happy to be with you all today. So we're going to spend a little bit of time talking about treatment and interventions and how we support folks who are dealing with issues around suicide. So we'll spend a little bit of time talking about some of the cultural perspectives on suicide. I think it's helpful grounding while we won't go in depth in terms of, and actually I think it warrants even saying directly that, you know, when we think about cultural perspectives, we will never be able to be experts as it relates to someone's experience. We learn as we go and as we study, but we will never be experts in that space. And so I think that that's important to note up front. But we will speak a little bit and spend some time talking about some of the different ways, different cultures and different races, what their relationship is to suicide and how it shapes their behaviors. We'll spend some time talking about treatment planning. We'll talk about some of the common interventions that we use. We'll talk a little bit about supporting clients after an attempt, and then also what do we need to do to support providers as they hold space and serve as containers for the folks who we're working with. So one of the things that's important to note, you know, I think the pandemic, I think it's always been something that's been critically important to do, but it's also really important to note that the pandemic has left many of us in a space where we are, as providers, now in a space where we can recognize and say pretty openly that many of the things, the emotional turmoils, and some of the mental health challenges that folks that we're working with have experienced, we have experienced them too. And I think that that's been a space where it's become an equalizer in some sense. And the call upon us to really think about how we work with individuals and think about it from a culturally responsive perspective is really, really important, and it's actually higher than ever before. And understandings of suicide, you know, are often influenced by culture, right? We'll talk a little bit more about this, but there are some cultures that connect to ideas around suicide, not in a way that is pathological, actually. And I don't know how many individuals, I'm curious to know how many folks in the room would say that the majority, so let's say maybe 51% of the folks that you serve look and have different cultural experiences than you. People would say that. Okay. How many people would say at least 51% of the folks they work with would identify as being BIPOC? So Black, Indigenous, people of color. Yeah. Okay. 51%, so the majority. Yeah. Okay. Okay. So it's going to be really important to think about those cultural expressions, right? As we're working with individuals who might be different than us. It's important to note that oppression, racial trauma, displacement, issues around perfectionism even can be influencers of suicidal ideations and suicide attempts and suicide, right? They're not always, suicide is not always viewed as being taboo in all cultures, right? So as individuals, and particularly as individuals who are charged with the responsibility of preventing and stopping a suicide, it really creates this sort of cognitive dissonance, does it not, in terms of recognizing that someone who might be sitting in front of me might see suicide as as an expression of a social obligation, as an example, right? And I'm in a position of trying to prevent that from occurring, right? So just really important to think about that. You know, there are, it's particularly true when we think about cultures where family honor is really, really important to keep that in mind. So I want to talk a little bit about Indigenous communities, and actually I've included the resource for where this information came from in the resource part of the presentation. You'll find it in the slide deck in the app, but I actually found this pretty interesting in terms of thinking about this, and I invite you to think about it as it relates to what we see as being normative, and what we see as being the sort of place of grounding within Western culture, and thinking about how that might be different or different ways that you might consider these things if you're working with folks, particularly indigenous communities. So suicide expresses this sort of underlying pathological problem, right? And I would invite you to consider that some folks who are within indigenous communities might see this more as a historical expression, of family disruptions and community disruptions, right? So it might not be viewed as something that is pathological or intrinsic to some maladaptation or dysfunction within the individual. And then also, thinking about suicide as being primarily this sort of self-motivated expression based on some sort of unrest that this person is experiencing, but rather one might consider that it might be reflective of a social obligation, as I mentioned, within certain cultures, right? Also, I think it's important to think about how we as providers think about suicide as being best addressed within the mental health context, right? Now, I'm a licensed clinical social worker. The other thing that you don't know about me is that I'm also a public health practitioner. So like when I say this, like I'm the ideal of like what we're talking about when we say that sort of the thinking about suicide and the treatment of it as being solely or best addressed within the medical industrial complex, right? Like, so I am that person. And so really thinking a lot about how we can start to consider that there are other ways of being and other things that are helpful for people to address some of the mental health challenges that they're experiencing. And really thinking about suicide, that one of the delivery systems might be within the mental health realm, but it's also very true that thinking about mental health services and what is helpful for folks might actually rest within a decolonization framework. So what do I mean when I say that? If we consider the fact that oftentimes some of the traumas that people experience that sort of lead them to a place where suicide has become their primary option, many of the things that folks are experiencing and dealing with are socially constructed traumas, right? There's a really fascinating work by Dr. Wendy Shia, who's based out of University of Maryland, the School of Social Work, and she talks very much about socially engineered trauma. And one of the things that we know is that we often ask people to recover from things that should never have happened, and that are systemically generated, that have caused people to have significant unrest in their lives. They make their lives feel unmanageable such that suicide becomes their primary option. And so when we think about that, to consider the fact that there are ways that we can work with individuals and promote people working within their communities to address some of the unrest that exists within their lives that cause this sort of emotional turmoil that they're dealing with is something that I invite people to consider. So it could be that you're not necessarily or only referring someone. So how this looks in practice could be that you may not only be referring someone to see a psychiatrist for medication management, right, if someone is depressed, but you might actually be recommending that they go to a healing circle, right? Or you might be recommending that they engage in a yoga practice with people who have bodies that look like theirs, right? Or with people that look like them. And those things have tremendous value in addition to the work that we do. In some ways, I recognize I'm talking myself out of a job. However, I can live with that. I can be okay with that. So another thing I want to sort of lift up is some of the work in African American communities. And I'm a person who identifies as an African American. I work primarily with African Americans. I grew up in an African-American community, and so I bring to this, we talked a lot about lived experience throughout the course of the conference, and so I come to this part of the conversation as someone who is clinically trained, doing work with African Americans, and myself bringing my own lived experience to this as it relates to my experiences with folks. But I will say that there can be, and I think another thing to say, I'll stop parenthetically to say this because I think it's really important, I probably should have said it a little bit earlier, is that when we think about culture and we think about race and things and how things show up within certain racial demographics and cultural experiences, it's also important to note that people are not monolith, right? So as much as I just said that I bring my lived experience to that, and I talked about being an African-American woman, it's also important to say that I'm an African-American woman, I'm a cisgendered African-American woman who grew up in a middle-class family, right? Which is in an urban society, right? Which is very different than someone who may have grown up in the, with maybe the same phenotype who may have grown up in the South. So I think that's important to note because we don't want to ever sort of think about culture or race with there being sort of one way for folks to be and show up. Now that said, one of the things that I have seen in folks that I work with is that there can be some reluctance to seeking help. And that reluctance is valid, okay? People have reluctance to seek help, and it is valid. And it is valid because historically things have happened that have not made help seeking safe. And I like to say that when we think about seeking help and coming to someone, help is defined as helpful by the person who has to receive what you're giving. It's not defined by you. Right? So as an example, I'm a person, I don't like avocados, right? But if I'm hungry and that's what you keep giving me, I'm not going to find that helpful because I'd have to be pretty hungry to eat an avocado or anything with it in it, right? And so I'm not going to find that tremendously helpful. So I think that's important to keep in mind. The other thing that I think is important to consider is that you want to use words that are non-pathologizing, right? So I have found just the slight switch in using the word counseling versus therapy has helped people engage better. And I'll tell you why. I think therapy oftentimes, in my experience, and I've been doing work in the homeless space. I've been a social worker for over 20 years, but I've been doing work in the homeless space for about 13 years. And so I've seen that it is more correlated with people's own feelings around being considered crazy, right? And needing treatment, which is more aligned with things that need to be fixed, which means that there is something broken, which then connects to something being innately wrong with me, right? And so if I don't connect to that, then I'm not going to connect to anything that's sort of aligned on that spectrum, right? So I think that's important to note. And then if you're talking about psychotropic medications, and someone is, experiencing really deep depression, has had, suicidal attempts in the past or suicidal ideations, one of the things that I think can be helpful is to talk about medications as a way to sort of stabilize things as opposed to treating a disease or a disease process. So, and I think I've used talking about it in the context of diabetes and hypertension, I have found to be very helpful with folks. To talk about is stabilizing blood sugar. So, taking a medication that helps to stabilize brain chemistry to help you feel better, sort of like how you take insulin to help stabilize your blood sugar, right? And then I think also considering spiritual support and fictive kin in care and treatment planning is critically important. When you think about a African-centered worldview, oftentimes it is one that is based in collectiveness and community. And so when it's very possible that if I say my aunt, I might not mean my mom's sister, right? I might not mean that. Or if I talk about my grandma, I might not be talking about my dad's mom, right? And so, but those folks are extremely important. And so it's really critically important to think about that, because I think as folks are dealing with really difficult emotions and considering suicide, having that village is going to be really, really important for people. And I think as providers, we want to be very mindful of not considering involving other people in care, or when other people insist on being involved in someone's care, as being an enmeshment, right? Which for the social workers in the room, that's something that we typically look at as being something we want to stop or prevent from happening, and we see that as being pathological, right? When other people have these really intertwined relationships, and we sometimes see that as being pathological, but it can be very helpful, so. So I'll stop here to do a little bit of it, and I guess I should stop and ask if there's any questions about any of that, or any thoughts. No? Okay. So we'll talk a little bit about treatment planning. And so treatment planning is pretty synonymous to how you do treatment planning in general, actually. I think what you put in your treatment plan is much more specific as it relates to suicide prevention, but one of the things you want to do when you start to consider a treatment plan for someone you're working with is actually to start with yourself. You need to start with yourself and check in with yourself about where you are and how you are managing your own emotional reactions to suicide, right? Or suicidal ideations. You know, as Lynea so succinctly stated, you know, it can evoke this sort of panic, fear in us. That fear can be very contagious. So in the example Lynea gave, it's this idea of having someone who's expressing a suicidal ideation, you becoming very panicked, you call 911, that panic gets transferred, and that kind of thing can have really deleterious consequences for the person who's there who needs help, right? So it's really important to start with yourself and to check in with yourself about what's happening with you emotionally. It's also critically important to establish a therapeutic relationship, an alliance, right? Being that person who someone feels that they can come to and talk to and connect with is really important. So just like be a person, be a human. Like look at someone, see their humanity, let them see yours, right? Put the agenda to the side, put the assessment tool to the side, and just be. And let your presence be a regulating presence for the other person, right? It's like that use of self that we often talk about in social work practice. You want to honor the person and center their lived experience. So as you're talking with them, asking them, what has worked for you before, right? And what makes suicide your first option? That's one of the questions I love to ask, because I think we have a little bit of a fallacy to say that suicide won't be an option that people have on their menu. If a person's in really deep despair, I can share a situation we have going on in our clinic right now where someone lost their child to pretty significant violence, and that person, this was their number one menu item, was suicide, you know, and attempting suicide, you know, and the question is like, what makes this number one, right? I mean, I don't know the deep despair of what that would be like. I hope never to have that experience. But it's hard to imagine that might not be on the item of things you're considering. But what makes it number one? And if it's been number one, what stopped you from carrying it out, right? Because people have done things that have worked for them in the past. And the human will to live, as Lynea noted, is extremely strong. And people have been saving their own lives for a very long time, actually. So as you start to get into sort of the nuts and bolts of doing treatment planning, you want to think about it in the context of SMART goals, you know, the things that we do just generally when we're doing treatment planning. So for folks who don't sort of know what that acronym stands for, specific, measurable, attainable, relevant, and timely, right? So you want to make sure that the goal is specific. You want to base it on what is actually they're saying and what they wish to accomplish, right? You want to think about it being measurable. So you want the goal to have some ways that you can monitor progress. Timelines are really helpful as well. You want it to be attainable. So you don't want it to be so challenging that, like, the person can't actually do it, right? You want it to be relevant. So it should be appropriate for the current situation, what they're trying to, for the individual and the situation. And it should be timely. So you want to have those clear timelines that are realistic. So I give a couple of examples here, just of some things that you can consider. So I won't read them, but you'll see that they have timelines, they have specific actions, they're relevant to the issue of suicide. So just as things to consider. So as we think about treatment planning, the other thing that we want to also consider are the interventions that we use when we're working with people who have expressed suicide as their option. A couple of things that you should consider are some of the brief interventions. We talked a little bit about safety planning previously. In the current moment of a crisis, we'll talk a little bit more about safety planning as a tool to intervene and to plan preemptively for when someone is experiencing or before they start to experience a crisis. And we'll talk a little bit about lethal means counseling too, which I think is really, really helpful. We'll talk about emergency petitions, and I'll be very brief about that because one of the things that about emergency petitions is that it's always an option. It is a point of intervention. When I say emergency petitions, people probably have different things they call it in their communities, but essentially it's when someone has made a determination that this person is too at risk to keep themselves safe, right? So in the instance of a person who has active suicidal ideations, they have a plan, they have a date, they have intentions, they have means, all of those things can identify no family, no protective factors, and are dead set on carrying this out. That would be someone who a provider would intervene to have that person taken to a place of safety so that they cannot carry out that act. So in Maryland, those individuals are licensed clinical social workers who have this authority, police officers have this authority, psychiatrists, psychologists have this authority to do that. And so what that means in our community is that the person we complete paperwork, we say they're unsafe, they're held for 72 hours, evaluated by a judge who then either concurs and say they need to stay in the hospital for longer for treatment, or decides they're doing okay and we'll let them go. So this is always an intervention. I would say it's one that you should use with a lot of forethought. It is one that is not without harm, and I think that's worth mentioning, because the very thing that you do to try to keep someone alive could be the very thing that causes them harm. And that is not to shame providers in any way, because there are instances where it's absolutely necessary, but just to also acknowledge that there might be some reparative work that needs to be done with folks, and that taking away anyone's rights for any reason, even if it is to keep them alive, doesn't feel good usually to the person. Even if they're grateful that they're alive, it can be hard for someone to have their agency taken away. So I do it with a lot of caution. I think it's really important to not do it from a standpoint of, grounded solely in this sort of idea of better safe than sorry. Kind of thing that I think oftentimes, or grounded in this idea of primarily like CYA. Do people know what I mean when I say CYA? Okay, all right, I won't say it. I won't cuss, but yes. So you don't want it to be primarily grounded in from that perspective, right? And then we'll also talk a little bit about warm handoff. Okay, so safety planning intervention. It actually was developed by two docs, Barbara Stanley and Gregory Brown, and it centers collaboration between the individual and the mental health care provider, right? It's personal, it's unique, it should be very specific and tailored to the person in front of you. So this is not the kind of thing where you kind of like pre-fill out and say, these are things you can do and like give it to the person, take a walk, you know. I remember being very new in my own practice years ago, telling a client, first mistake was telling a client, so don't do that. But I was telling a client that going for a walk could really be great for them. And they're like, have you seen my neighborhood? Like, I'm not going for a walk around here, right? So it's like you have to really make things very specific to the individual. And then you want to just identify actions that people have found helpful at earlier times in their life, right? People are really good at like saving their own lives, right? So it's important to recognize that. So this is the safety plan. It's the same one that I think you all have at your tables, but I'll stop here to say that as you work through these with individuals, you'll want to think about what it is that they see as warning signs to when things are kind of going awry, right? Like what are the thoughts that they're having? What are the images that come up? How do they know within themselves when things are starting to go sort of, when they started to decompensate? Right, those are the things that you want to be exploring with people as you plan preemptively, right? And the reason why you want to know this is because you want them to tell you what you should be looking for too, right? So part of this is helping the person to acknowledge these things within themselves, but also as these things can be indicators for you. I recently worked with someone and she was telling me that her depression gets really, really bad. And I said, well, when it's at its worst, like how would I know? Like we're just meeting each other, so I might not know. How would I know if things were really like off the rails? She's like, well, if I go missing for 30 days, like that's when it's really, really bad, right? And I said, okay, what do you think about me maybe checking in with you or like calling your mom if it's been like 30 days and I haven't seen you? And she's like, no, maybe not. And I said, well, what about if like I called it like 35 days? Would that be okay? She's like, yeah, that's okay. You know, so I think it's really getting people to sort of talk about what that looks like. And then you also want to get people to talk about like what are their internal coping strategies. And this is really interesting because we often talk about where the supports are. We don't always think about how people can support themselves, and it can be really empowering for people to know that they actually have agency and like knowledge and internal ways that they can help themselves feel better, right? And helping to actualize that. Sometimes I even feel like asking the question can be a space where people can sort of like access this idea that they actually have something like worthwhile within themselves that they can do. So it's important to ask those questions. What can you do to take your mind off of things? I've had people say really interesting things like sing, you know, and then, you know, I say like, what's your favorite song? I had someone doing this some time ago tell me that one of the things that helped them feel better was just like humming Jesus Loves Me, right? If that works for you, I think that's great, right? And that's something you don't need anybody else to do in order to access that for yourself. So you do want to identify social supports and people that can be helpful too as distractions. And then noting the people that you can ask for help. Right? You want to try to, as much as possible, not have this be the therapist, the psychiatrist, the doctor, right? You want to try to, as much as you can, and recognizing that sometimes that is who it is. And if that is who it is, it's okay. But I think sometimes the default can be like the emergency crisis number, the therapist, the psychiatrist, and it's really helpful to imagine what it could be like for that person to identify someone in their natural environment that they can call on to help them, right? You want to talk about professionals, and you want to also talk about making the environment safe and what it takes to do that, right? So if you have insight into how someone may have attempted to kill themselves in the past, then it would be helpful to know that. So if you know that the person has typically used sleeping pills, I mean, that's a question you want to ask pretty directly. Do you have any sleeping pills at your house or anything that makes you really that's a sedative? Okay, even things like, I'm talking like PM Tylenol, like anything that has any kind of Benadryl, any of those things, right? Do you have those in your place? How do you keep them? Where do you keep them? When's the last time you thought about taking them? If you thought about it and you didn't, why didn't you, right? Do you think you can give those to someone? Also, so talking about that leads right into lethal means counseling. And it really is it's means reduction and trying to reduce the vitality of, or the lethality of an attempt, right? So if a person, the less lethal the means is, the more likely it is that it will be unsuccessful. So as I'm targeting and sort of assessing the things that people have access to attempt suicide, I'm thinking about things that are pretty easy for you to be successful, right? So I'm starting thinking about guns or knives, pills, those kinds of things. But really thinking about that in terms of trying to remove those from the environment. So, and the basic goal of this is just to try to get those things secured so that they don't have that access. And recognizing that a suicidal crisis can escalate pretty quickly. So if that thing is harder to get to, it puts a little bit of time between the thought, the feeling, and the act. It's a very impulsive act, right, when these things happen. So, and if the person doesn't have the access to something that could kill them, they don't die, right? So it really involves these steps here. So first you want to express concern for safety. You want to always situate it in a desire to keep things safe. You want to let them know what they can do to create a safe environment. So that's that assessment of what they have, what's there, how they've tried to kill themselves in the past. Has it been successful? What happened? You might have someone that says, oh, I took, a bunch of Tylenol, and it's like, well, what happened? Oh, I just threw up, right? So I'm going to be less focused on that because, it's crummy to have a tummy ache. But if you have a tummy ache, you're alive still, as opposed to if you have knives or guns, and that's something that you would have used or would consider using. And then also, explaining how lethal means work. So talking about that you can't predict crisis, and that's the reason why you want to sort of minimize access to these things, not as a means of control, right? But to intentionally put some distance between the emotion and the thought and the feeling and the action. Right, so explaining that to folks. And also, during those moments of acute risk, the need to reduce that access it's a primary focus. And people typically don't switch from one means to another. In your own work, I'd invite you to consider if you've had someone who's expressed a desire to die by suicide, have they been very open to say, oh, I could walk in front of a bus, or I could take pills. People typically have a way that they've sort of conceptualized in their minds about what they envision this end looking like, right? So getting to know that can be pretty helpful. So another really important intervention is the warm handoff, right, and the power of this. And I think this is something that actually can prevent, or can sort of present a gap in our healthcare system to some extent for many reasons. So I want you all to know that you have pretty tremendous power, actually, and influence over helping a client connect to other services that they might need. And this is where that use of self is really critical, because as you work with individuals, you're working with them, you're in community with them, you're building alliances with them. And oftentimes they trust you. They have come to trust you. And so if you are helping them to connect with another service, sometimes people will, like, you use your credibility to vet someone else, right? I talk about this a lot as it relates to peers. Oftentimes, peer workers are vetting me, right? Because I'm, as a licensed clinical social worker, I'm coming with all of these agendas and like all of these assessments and all of this stuff. And sometimes it really is just like a peer saying to the person, oh no, Miss Lawanda, she's cool. Like, she's been here a while, she's cool, she's good people, right? And then they're like, okay, I'll see her, right? So it's one of those things. And so I think it's really helpful to think about the influence that you have to connect people to the things that they need. You want to try to directly introduce the client to whatever that behavioral health resource is or community resource. You know, if you can make that connection, you want to do that directly. So it's more about not knowing the person needs to see a psychiatrist or wants to see a psychiatrist and like calling the place and saying, or here's the number, but actually sitting down and calling with them, or when they get an appointment, actually being with them or helping them to make that connection whenever possible. And it's actually very powerful if you can do it face to face. Some of the most meaningful work that I've done with people who have been chronically depressed and suicide has been an issue for them, or attempts, has been to actually go with folks to their initial appointment, right, whenever possible. And that might be, it might not be in everyone's community that the therapist can do that, but maybe it's a peer who's making that connection and helping them, or a community health worker. But if you can do that, I would encourage you. I have found it to be tremendously effective, and just to help people navigate the healthcare system. When people are in crisis and feeling really lousy, it can be, behavioral activation can be really, really hard. It can be very, very hard. And that's not synonymous to people like being non-compliant or like not caring or this not being important. Something can be tremendously important to people, but they just don't have the energy to like become activated to do it. And so having someone there who's actually concerned and will walk alongside them can be really important. So you want to know the referral source in advance. If you're working with people who have experiences with suicide, you want to know what some of those referral sources are. You want to also know what's in your community and some of those sources that are that might be more culturally specific. You want to know them in advance. If you have a client who you want to refer to someone, you want to talk about your concern with the client and your concern and care about them as a person, right? You want to also make sure, so this is like the administrator and me, you have to follow your agency's protocols. You got to do it the way they say, right? Document it the way they say. You have to do those things. You want to follow up with the referral source to actually determine that it happened, right? I would say this. Sometimes we ask, we'll ask the client, did they go? And depending on how I ask or what they think I want them to do might dictate the answer I get, right? So you want to follow up with the referral source to make sure that there was a connection that happened, right? And if you can follow up with the client within 48 hours of when you knew they had the appointment, that's really, really helpful, right? So if I know your appointment was on Tuesday at 10, I might call you on Thursday and say, hey, how did it go? Did you like the person? Did you like them? How, do you think you'll go back, right? Great, so just check time here. Be sure I'm good. Okay. So care after a suicide attempt. I'm going to talk a little bit here about care transitions, which I think is another space where there are opportunities for us to think really creatively about how we do this. How many people in the room are working? So I talk about this and I think about it from the standpoint of people who are working in inpatient settings and then folks who are working in community settings. So is there anyone here who's working in an inpatient setting? Like in a hospital, in a psychiatric ward, anything like that? Residential treatment, okay. The lone person, okay. So this is some of the things that I think can be really, really helpful. So, inpatient care is not designed to be the person's total care, right? It is an entry point. And it's designed to be an emergency kind of situation to mitigate emergency immediate risk, right? It's not supposed to be the end-all, be-all. And it's only intended to be care that helps to get people back to a place of like homeostasis, right? So the first week after discharge, I imagine many of you know, actually carries a very high, it's a very volatile time for folks who are coming from a psychiatric admission like that first week. Because people often are actually feeling better after a hospitalization, and so when we think about that behavioral activation, people actually have more energy to then carry out the things that they may have been too depressed to do previously, right? So that's a time that you really have to be connected, or you can lose people, both like literally and figuratively, right? And then also, when you think about that transition from inpatient to outpatient care, it is a gap in our continuum. I think we're still trying to figure out how to best do that. Some of it is related to resources and time, right? But that is a gap there. So when you think about inpatient providers, one of the things to consider, these are just some best practices that actually came from some references from SAMHSA actually, but one of those things to consider is that you want to begin the discharge at the time of admission, right? So you ever hear the expression like discharge planning starts the day of admission? That is best practice. You want to have collaborative protocols, right, where you're working with folks in the community, you have a good sense of what service providers are in your community. You want to do things like electronically deliver any critical paperwork to the outpatient provider before the patient or client leaves. You want to make sure that they have what they need to be able to continue the plan of care or modify the plan of care before the person leaves, right? If the person's inpatient, you want to encourage family participation. You want to keep in mind that family is self-determined and self-defined, right? So it could be a neighbor, it could be boyfriend, it could be, mom, dad, it can be whomever. And including peers, right? Peers are uniquely positioned to be able to connect to people in a low-demand relationship that's centered in lived experience, shared experience, common experience, in ways that look very different and can be helpful in different kinds of ways for folks. You want to engage community supports that are important. So we're talking about things like shamans or priests or anything that people have found to be really helpful to them in their communities. There are times where you might consider, things like boxing camps, right? Any of those things that people find useful. You want to have a safety plan coming out of an inpatient hospitalization. You want to make sure that you have scheduled outpatient appointments within 24 to 42 hours of discharge, because we talk about that week window being a really critical time. And you want to find innovative ways to connect with providers. So inviting people to come for treatment planning, if you know who the provider is going to be, or that person was already connected with care, reaching out to them, that community provider, and asking them to be involved, right? Asking the patient if they can be involved is really helpful. And one of the other things that I found in the guidance document around this that I thought was really interesting is this idea of caring contacts. So really what it is, they talk about just sending like text messages or like a inspiring note. And they talked about how just having those things and connecting with someone, not in ways that it requires the client to have to do something, but just letting someone know that they are thought of and that they are regarded and that they're on someone's mind can be really helpful. So like, I'm not engaging you because I want you to do a bunch of stuff. Like, I just want you to know that like, I thought about you and I hope you're well. And I hope you keep pushing, right? So conversely, there are some things that are recommended as it relates to what we can do as outpatient providers, which I'm imagining if there's only one inpatient provider, everybody else is in outpatient settings, right? Yeah, so I would say that, trying to cultivate a transformative relationship rather than a transactional relationship. When I say transformative, it really is like deep connection that is not just about what I need from you or what I need you to do for this patient, but we're in relationship and partnering, right? So we have an ongoing relationship. That's the kind of work that I think can be really helpful in bridging those connections. Taking shared responsibility for the patient, seeing it as your role to make sure that that person gets to you after a hospitalization. Making sure your staff are trained on suicide prevention, not just the one lone social worker who's like the suicide lady, right? Or suicide guy, but like making sure that everyone sort of understands what it means to intervene and be helpful to someone who's having a mental health crisis. Narrowing that transition gap, trying to create ways that you look at your scheduling and really strategic ways to have spaces carved out for same-day appointments, and next day and week-long follow-ups, those kinds of things. So thinking strategically on the operations side for those who are in administrative spaces to consider how you do that, right? So supporting providers. Couple things. So suicide is often a loss that we don't talk about. When we talk about clients who have passed on that we've worked with, we often don't talk about the impact of suicide on us as providers. It can be detrimental to the health of the mental health, like the mental health of the provider, and I think that's something we don't often recognize. And it can result in these sort of personal and professional responses in us. So things like second-guessing yourself, as a professional, feeling incompetent, blaming yourself, professional isolation even. If other folks are feeling like you should have, I think this often can kind of generate the shoulds, right, that kind of permeate in people's brain when something like this happens. And also the fear of blame and litigation, which is real, right? I have seen that fear of blame and litigation manifest itself in things like defensive documentation, moving more towards this idea of better safe than sorry, right? Sort of catastrophizing, like professionally, right? Overreaction, right? So those are some of the ways that this can manifest. And then I think just personally, things around shock and fear and sadness and despair, intrusive thoughts. The literature talks about lack of sleep as well. So we want to make sure that we are providing support to individuals who are doing this work. This work is hard, it's rewarding. I love it. But it does come with challenges, right? And so we want to make sure we're doing things like providing individual supervision. We want to, as much as we can. I think there's a lot of value in group supervision where people are sort of learning and gleaning from other people's experience and the sharing of experiences. And I know when I talk about this work, I often ground it in context. You probably notice I give a lot of examples of my own work. And I think that can be helpful to folks. And then also, too, thinking about something called critical incident stress debriefing, which is actually something that's birthed more out of like emergency response kind of work. So thinking about like paramedics, police officers, that kind of thing. And then also individuals, veterans as well, or soldiers. But this also can be applied and has been applied and talks about it in the literature. I included a link here to some information about it. But it also is applied to individuals who are dealing with like any kind of traumatic event. And losing a client to a death by suicide can be a really traumatic event, right? So there's 7 sort of steps to the critical incident stress debriefing model. And there's introduction, a fact-finding phase, a thought phase, reaction phase, symptom phase, teaching, and reentry. So ideally what you want to do is provide an opportunity, and I won't break down all the phases, but the document that I included does have a very detailed sort of outline of them. But suffice it to say, the goal of this is that you want to provide an opportunity for people to be able to introduce themselves and to talk about how the event impacted them. So you want to ask them questions around what are the facts as they know them, how were they involved in the incident, because people are going to be connected to this in different kinds of ways. Someone mentioned earlier about being the person who's at the front desk who sees them every day. So they weren't charged with their care, but they exchanged pleasantries with this person all the time, and like, they seemed fine. They seemed fine. Like, I didn't know this was going to happen. They seemed okay, right? If I had known they were struggling that day I saw them, I would have referred them to the therapist or asked them where. So you get what I'm saying? So people will have different ways that they connect, right, to these kinds of incidences. And so I think that's a really important component. The other piece that's really important is in terms of the reaction phase, that's really where the facilitator is going to be hearing how people are reacting and making, sort of noticing where people might need different kinds of supports, right? And allowing people a space to vent so that they can think about what is next, right? Because when people don't have an opportunity to sort of unload that, people sit and ruminate with the things that they could have done or should have done or would have done, or did I do more, did I not do enough? And so this provides a nice model for that to happen. Typically, this is, again, utilized in work settings that have high exposure to traumatic events, and it's actually best utilized within like the first 24 to 72 hours of the incident, right? Or when you became aware of it. So sometimes you might not know that someone has attempted suicide or that someone has died by suicide until later, but so the point of knowing within 24 to 72 hours there. And these are resources that I have included here in the PowerPoint slide, so please take a look at them. Yeah. Any questions about any of that? Yeah.
So I have a question about the suicide hotline that was set up for adolescents. And do you have any assessment of that service and what they're doing on that end regarding moving towards any of these themes or being scammed?
In terms of, so that's a pretty big question. In terms of like which component?
Asking about the quality
Oh.
of what is happening for the youth online.
Yeah, I mean, I don't have information on like the quality assessments. I would imagine it's probably still being determined, to be quite honest. I would say that I know different points. SAMHSA has done a lot of work in that space, kind of looking at that. I mean, we do know that the rates of suicide for young folks are like through the roof right now. It's certainly commanded a lot of our attention at the clinic, such that we have started to build in more supports in that regard, and are thinking really intentionally about how we have pediatric providers in place. And partnering with some schools to be able to bring folks in to work on that. In fact, it's been such an issue that many of so Salisbury State University, Morgan State University, and University of Maryland have partnered to create a program to specifically train social workers in the behavioral health integration for working with individuals, and so they have students who do their clinical rotations specifically focused on that population, and it's a paid internship with some federal funding. So yeah, so I know from that standpoint, it's something that's been a big initiative area in many spaces, but in terms of like the assessments of the quality of what's happening nationally, I don't have that offhand. Yeah. Okay. Just one more. Yeah.
I like the legal means concept because it's taking certain items and putting their environments that are able to, they're affected and cause them harm or disrupt to act out on suicide. But what about different like environmental things like jumping off a bridge or a highway or how would we address that?
Yeah, no, that's a great question. So I think part of this is also, like, when you're doing your assessment about how people are envisioning the end. So, like, I would ideally ask if someone is saying to me that they have plans to jump off the 83, right, which is like the highway right down the street, which would be pretty lethal, then one of my questions would be, like, how often are you in that area? What do you do down here? Okay, you got to come see me. My clinic is right across the street. Oh, what do we do, right? So, like, maybe I'm doing home visits with you for a bit, right? So, like, you don't have to come down to this area. Or maybe I'm transitioning, talking to your medical provider, and we're doing telehealth visits, right? Like, if there's not some reason why you got to get labs or something that we need to, like, have you in the clinic, maybe we're going to transition to telehealth visits for a minute, and I'm going to do home visits for your therapy sessions as opposed to you coming down to the clinic. Yeah. Yeah. All right. Thank you.
Thank you so much, Lawanda and Lynea. We are going to take a break now. We'll start back at 10:50. There is coffee and tea down in the main big hallway, so we'll see you back in a few minutes. Welcome back, everyone. I know folks are checking out of their rooms and doing lots of things, so we're going to go ahead and get started and know that we may have more neighbors coming back in as we go. I'm so excited to now turn it over to Bridie Johnson and talk about caring for providers and supporting each other. Would you like this one?
Yes, unless this one, no, okay, yeah, that'll work. Hello, everyone, hello, Annie, bonjour. I'm glad to see you all here. So of course, I'm not going to do any kind of land acknowledgement today, but I do want to say something about land acknowledgement because I think that it's kind of like becoming a thing. And the more important thing, I think, to think about this is in regards to what am I doing to connect with the people here that are still indigenous, that, you know, kind of live on the land that I'm working on, and then connecting people to resources, so understanding service as well, in making those connections is super important. And I just wanted to share that out. There was a 6th grade group that did a really good land acknowledgement here, and I think one of the most important, and in all of this will be at your leisure to read, and so know that these slides are heavy in words, but I promise not to transcribe them at all to you guys here today. But I just thought it was cute because the kids could think of so many things in their land acknowledgement that maybe we don't, so I left that there too. And of course, these opinions are of me. I'm one Indigenous person, and I do not represent Colorado Coalition's thought process. It's just me here sharing my own two-eyed seeing, we'll call it. So my Western medicine lens, and then my Indigenous life experience as well. So I wanted to start with this instead. The peace of wild things. When despair for the world grows in me, and I wake in the night, at the least sound of fear of what my life and my children's lives may be, I go and I lie down where the wood drake rests, in his beauty on the water, and the great Huron feed. I come into the peace of wild things who do not tax their lives with forethought of grief. I come into the presence of still water, and I feel above me the day-blind stars waiting with their light. For a time, I rest in the grace of the world and I feel free, by Wendell Berry. And I'd like to share that out because I think the grounding we talked about in here is really important, as well as literally grounding and taking care of yourself with Mother Earth and connecting your body, like the tree hugger mentality, right? And just kind of, taking your shoes off, not on the concrete, but on the grass, and taking care of you by vibrationally and feeling the earth that you're on. And so that's what we used to do with like a tobacco tie. We would lay sema, tobacco down, but it was really to feel Mother Earth and to connect with her in that way. So if you do that, it'll even help jet lag when you go from place to place. So put your feet on the earth if it's not too cold, and that will help orient you to the time zones that you're in. So just a couple quick objectives, and I promise not to read anything out. It was so nice to hear you speak earlier and tie in my little video, so I didn't have to say a lot around it. I feel like I can just let you guys listen to this and kind of think through an objective lens when we're thinking about self-care, when we're thinking about caring for each other, when we're thinking about caring for the people that we serve. Is that better?
I will shoot them all, I hear a voice of rage say. Unfortunately, this isn't the first time I've heard someone make such a claim in my office in 17 years as a therapist and a psychologist. I know I must keep the public safe in this situation, but what do I do to help this young man who's obviously in very, very deep distress? I think most people hear something like this and they go, I would want no part of that. I don't want to be in the room with this kid. For me, perhaps oddly, there's no place I'd rather be. I can't really explain it. I've always had this sort of odd ability to form connections with people who sometimes struggle to form connections. So I can offer that to this young man, and perhaps in this moment it reconnects him to society just a little bit. But this is probably not enough, right, for someone that's experiencing this level of distress. So where else do I turn? I can turn to psychiatry and psychology, and look, they've offered a lot over the last 100 years or so. Most of their interventions, though, locate distress, like the kind this young man is feeling, inside the person. Now, some of that is genetics and biology, right? And I'll talk more about that later. Some of it is the sort of fierce individualistic nature of the culture that we live in. Right? So do I take psychology and psychiatry up on their offer and locate this distress inside of this young man? Or do I go a different route, perhaps a more systemic route? Do I look at his proposal to indiscriminately open fire on his fellow human beings as one that has been co-authored by the culture of the United States? And perhaps co-authored in a way that exists just below the surface of his awareness. Now, when I say co-authored, I think I owe you a little bit more of an explanation here. What I mean are systems that put pressure on people's identities. Systems that have something to say culturally about who people can be and who they can't be. So a couple of examples. Guns in our culture, in the United States, right? Fair to say we have a unique relationship with guns. So things like the Second Amendment, right? The right to bear arms and the various interpretations of that. The NRA, the National Rifle Association. Now, you could think these things are good, bad, or indifferent. That's for you to decide. But it's hard to deny that these don't put pressure on people's identities. They don't have something to say about who people think they're allowed to be. Another one in the case of this young man, masculinity. What does it mean to be a man in the culture? How can men behave when they feel hurt, when they feel angry, when they feel disenfranchised, when they have a grievance, right? Now, I could give you many more systems that were impacting this young man's life, but hopefully this gives you an idea of what I mean when I say co-authored by the systems of the culture. Think of it this way. If this young man wasn't living in this particular place at this particular moment in time, Would he be threatening to engage in a mass shooting? And listen to my language, mass shooting. I mean, we've had to construct language to describe this, which I think is rather telling. Right? How is it that we've come to think of mental health as such an individualized project? How is it that we've come to think of people's relationships with guns as so individualized? How is it that we believe we can separate either of these from the cultural context in which they were created? I want to smash cut here to April of 2019. So earlier this year, a woman named Sol Paez traveled from Florida to Colorado with the alleged intent to open fire on Colorado school children. Now, this is an interesting instance because she's a woman, and historically most mass shooters have been male identified. But, according to multiple media reports, she was sort of infatuated with the Columbine shooters, so this idea of masculinity is still very present, even if she doesn't identify as male, right? And certainly the relationship with guns in the culture is still present. Right? So Sol Paez travels to Colorado. The day after she arrives, virtually all the major school districts in the Denver metropolitan area cancel classes. We're talking hundreds of schools, tens of thousands of students. Late in that day, they find Sol Paez dead, and I closely monitor the media reaction. And I hear things like this and read things like this on Twitter and the various social media outlets. Sol Paez found, the scare is over. Think about that more deeply for just a moment. The scare is over? The scare is over. This is the kind of idea you get when you locate distress inside of a person. What you get is a disordered person. What you ignore are the ways in which the culture is disordered. Imagine for a moment that you're an oncologist and you're working with someone whose body is being ravaged by cancer. You and your team, you go in and you remove a single cancer cell surgically. And you say, we've removed a cancer cell. The scare is over. Thank you, that's how I felt too. It's preposterous, right? Because we understand that this is one cancer cell among many others. Moreover, we understand that these cancer cells are threatening the very vitality of the still healthy cells moment by moment, right? So when it comes to cancer, we understand we must treat this systemically. Why don't we understand the same thing when it comes to mental health? Why don't we understand the same thing when it comes to mental health and gun violence as media pundits and politicians talk about ad nauseum? Why do we think that removing a person from a sick system fixes anything? Now, I want you to know that this idea of locating distress inside the physical bodies of people, this doesn't just impact my work in very sort of drastic situations, it impacts it in all sorts of situations, right? If I could back up for just a moment, though, the young man, I think I owe you an explanation. What kind of work did we do together? And I'm sharing this story with his consent, by the way. So I formed a relationship with him, as I said, right? That's a good place to start, but it's not enough. I upheld my ethical obligations to keep the public safe. But then in the days and weeks that followed, what we started to do is interrogate the systems that were putting pressure on his identity, as I was talking about earlier. As it turns out, he had adopted ideas about guns without his own consent. He thought these were the ideas you must hold about guns, being a man in the United States, right? So we reauthored this. We formed more preferred relationships with guns for him. We did the same with masculinity. You know, in the United States and perhaps other places, but we're here in the United States, there's a very narrow description for masculinity that one must fit into. He didn't fit into that, and for a lot of reasons then felt disconnected from society and from what it means to be a man. So we reauthored his idea of masculinity. Now, we could have stopped there, but it wouldn't have been enough because this is not an individualistic endeavor, this is a community endeavor. So what we did is we invited his family, his friends, to stand in support of this new identity. Frankly, it offends my soul when we think that we can pull someone out of a systemic problem, right, and blame them for that. So what I want to move towards is a more systemic model of care, right, and a less individualistic model of care. Right? Now, as I was noting, this is sort of heavy. Maybe it has to be. But I want you to know that these ideas of locating distress inside the bodies of people, this impacts all the work I do. I'll give you another example, if I might. Share a story of a woman a young mother who had given birth 4 or 5 months ago and was feeling very, very depressed. She said, look, all my family and friends say, take care of yourself. Self-care, right? You know, that term before, self-care. And she goes, look, I'm trying to do it, but it's not helping. And then she drops her voice to a whisper, almost as if she's about to say something taboo, and she goes, look, sometimes it's actually making me feel worse. Her head drops in despair, and then she says, I can't even self-care right. Those words still reverberate through my being. I can't even self-care right. Now, look, I think self-care came from a good place. It came as a way to try to invite care into people's lives. I think that's a good thing. Moreover, what I don't think may be so good is if we believe that the distress exists in the self, then how do we heal the self? With self-care, right? How might we do this a little more systemically? Now, in March of earlier this year, there was a study released by the University of Colorado at Boulder. It was examining what's called the candidate gene hypothesis for depression. Basically, the candidate gene hypothesis for depression is a lot of big words to say that there's a gene that causes depression. For the last 20 years or so, that's sort of been the trajectory. We thought it was only a matter of time until we find this gene. So these researchers looked over studies that had tens of thousands, even some studies, hundreds of thousands of participants, and much to their surprise, they found no support for the candidate gene hypothesis for depression. None. They were more shocked than anyone. The thing about this is that idea that depression must be of us is so deeply rooted in the water supply that we don't even think to challenge it. Now, I'm not here to say there's no genetic influence to depression. That's a bridge too far. I think there's probably genetic influences, right? What I'm worried, though, is that we're looking so much at the genetic influences that we're ignoring perhaps more systemic influences. Now, if I could go back to the woman I was talking about who was feeling depressed after giving birth, so what did we do together? Well, I asked her a question. I said, hey, if you lived in a society where male partners, and this is a heteronormative example, excuse that, it's just she had a male partner. If you lived in a society where 50% of all child-rearing duties were taken up by men, do you think you'd feel more depressed or less depressed? That was her reaction, and she goes, oh, less depressed. And would it surprise you to know I've asked many women this question over the last decade plus, and unanimously they say less depressed. Now, you could say, well, those are her words, she's just saying that. Well, we put this to the test. We get a systemic intervention. We invite her male partner in to stand in support of her in these ways, and do you know what happens to the depression? It starts to go down. If this is something that's located solely in her, then why does a systemic intervention cause it to go down? Right? What it seems like we're doing in this case, and other cases like it, is we're asking a woman to self-care her way out of social inequity. That feels like a bad recipe to me, okay? So what do I propose as an alternative? Maybe we call it communities of care. Now, when I say that, the first thing people think is, oh, it's like group therapy, people getting together and talking about distress. While I think that can be lovely, I think it ignores one very important variable, and that variable is power. Right? When I talk about communities of care, well, can you imagine for a moment, like for those of us who have relative positions of power, right? If you go, oh, communities of care, this sounds very kumbaya, this is great. If you start doing this work, I'll warn you, it's painful, because what you start to do is you interrogate the systems in which you have power over, and you often find out that you are holding up values and ideas that you don't even stand for. But those values and ideas are so deeply woven into the culture that you don't realize you're standing for, right? Now, this could be at home, this could be in the workplace, this could be in your community, right? It could be all over. I can't tell you how to interrogate these systems because your systems are unique to you, but I feel like I owe you a general example. So let's take the workplace. In the workplace where you're in a relative position of power, are you dehumanizing, even if unwittingly, dehumanizing people through overwork? Are you defining their character, their worth as a human being by whether or not they produce? Right? These kinds of ideas. If we start in our relative positions of power to change these systems, guess what? People don't have to self-care their way out of them then, right? Because we are systemically taking this on. Look, the way self-care currently exists, largely in the Western world, is a lot like a boxing match. You have two people in the ring beating the hell out of one another. They go to their neutral corners for 60 seconds. They put the little glue over the cut so it doesn't gush blood, and they put some ice over the swelling to bring it down. But the problem is, we send them right back into the ring to start getting bludgeoned again. And I don't think this is a sustainable model. So do we, thank you, do we have the courage, like when we see this young man who's threatening violence, do we have the courage to say, no, we're not just going to pick him out because he's problematic. We're going to look at the ways in which the systems we're a part of are holding up the very values that are pushing him to this point. When there's a young mother, right, who's feeling depressed, do we tell her, well, she needs to go get treatment, or do we look at the ways in which we're upholding systems that help along this depression? Reimagine the possibilities for a moment. If we begin to understand that your care is bound up in mine, and mine in yours. Thank you.
Sorry about that. So doing the work that I've done for quite some time in Indigenous communities, if there's one person that's not whole, no one in community is whole. Oh, use the mic, Bridie. Does this one turn on or no? Well, that's all right. Okay. I wanted to take just a look at some of the rural facts. Working in Colorado Coalition, I'm in Denver, but we also have a very rural location that we try to do services in. And we need to think about, as we're taking care of ourselves, do we have what we need to do the work that we need? And so I do like to bring out rural statistics, because I always thought I had it bad in the city until I went there and did the work and had to find someone 40 minutes away if they were able to find someone that could do treatment and kind of assist in that way. Oh, sorry, yes. Isn't that amazing? I actually saw him speaking in Denver, and that was one of the most powerful things. And so I do have the link. I cannot remember his name offhand, I apologize, but I do have the link at the end of my PowerPoint so that you can actually go right to it and grab that. Thank you for sharing that with your staff too. I do think it's super important to kind of rethink the way that we put ownership on the people that we serve and each other. Yeah, no worries. So this is a provider who had an experience of, someone who had completed suicide, and then what do we do from there, right? How do we go back into work and kind of feel this, feel all the feels that we need to feel when we're doing the work that we're doing? Because it's hard. I found myself dissociating to a point of, my father had a house fire last year, and my sister's response to me, because I was like, okay, he's got insurance, check, he's got money, check, he's got somewhere to stay, check, he's got, these, so I was like, oh, privileged, oh, so glad. So I kind of didn't worry about it as much, and my sister's like, how can you be a social worker? You are just the most selfish, unrealistic, because I had dissociated so quickly from that experience, because I do that every day at work, and I do that every day, in my own life. And so I just quickly did that, and I was like, wow, I didn't even say those things that I was kind of processing in my head to make it feel okay, right? With her. And so, I said, I'm so sorry, and I'm so glad I can't social work my family. It got me out of it, the ethics, it was great. But anyway, so it brought my eyes to, some different thoughts around how we do what we do, how quickly we do our assessments, and we do our supervision with our staff, and we're bringing them in, and we're bringing them out, and they're dealing with these kind of things, and then we're kind of cattle prodding them, right out of the way. So just making sure that you take a moment to have space for your staff and for each other and for yourselves, I've been doing this work for 27 years, and one of my ex-partners completed suicide in December of this year, and I hadn't seen him in 12 years, but that didn't make it hurt any less or make me feel any less responsible. Like, how could that happen? You were with me. We did this work, but when you take somebody who's interested in community and you throw COVID in the mix, and they didn't really have a family, they had a heroin addict who had passed as a mother, and, a couple other people that didn't respect them for being who they were in their lives, but it was their dance crew and their roller skating buddies and their capoeira people that kept them abreast, right? And then when COVID came, all that went away. So I started to look back in their social media, and I saw, wow, July of 2021, it got really hard because there was no more threats to the government, no more isolative thoughts, no more nothing. And so then it didn't even happen until this December. So just thinking about all that time and space that was left with someone I cared about at one point, and I never even went back in to look and see that. So making space, for all of that, and for acceptance and for feeling okay thereafter can be one of the hardest things. So I kind of liked how she displayed this, and I hope you're okay with me breaking it up. We've done a lot of talking at you, and so I feel like sharing with you would be powerful.
For so long, I had saw myself as deadly. I didn't pull the trigger. I didn't even get him the gun. But for so many years, I felt that I had killed him. Losing someone to suicide has this way of playing with our minds, of convincing us of things that are actually not even based in reality. We know that suicide is a taboo topic, that the mere mention of it is enough to create awkwardness, anxiety, and even silence. And to be honest with you, as the date of this talk approached, I found myself suddenly asking the question, why in the world did I ever agree to do this? That the thing I had been so confident about suddenly became the reason that I wasn't sleeping at night. The idea of being up here and speaking to something so personal and so deeply painful began to feel like the biggest mistake. As a psychologist, I'm intimately connected to the topic of suicide through therapy practice, research, and even trainings that I conduct. And one of the things that I've recognized is that we need to be able to break this silence that exists around this. And this is what I want to do today, is I want to be able to start the conversation and to break that silence. Because what we know is that every year suicide rates are on the rise. In the United States alone, last year, 47,000 people died by suicide. What we know is that every 11 minutes, a new suicide is completed, and which unfortunately means that by the time I finish this talk today, we will have lost another person. So if we can break that silence, again, we can start the dialogue and we can start the conversation with each other. What I want to acknowledge today is the fact that I can imagine there are a lot of people actually in this room that are part of the community of those left behind by those who have died by suicide. And the reality is that if you're not, someday you might actually be. I remember actually when I was in graduate school, I had someone actually tell me there are two types of therapists: those who have lost a client to suicide and those who will. So what I want to do today is I want to share my personal story of losing a client to suicide, and I want to explore the two primary lessons that I learned in navigating this trauma. And so my relationship with my client actually started off pretty rocky. In our first hour-long appointment, he spoke a total of 5 words. 1 hour, 5 words. Seriously, I counted. There was nothing else to do. He challenged me on every level to have to learn, how do you develop a relationship with someone who has worked through and tried to process his own trauma for so many years that he has pushed everyone away just to keep himself safe. As the months and months went on, our relationship grew, and so did his trust in me. He started opening up more. In particular, I remember that he talked a lot about this book he was writing, and even brought chapters of the book into our sessions to be able to share with me. This book was about his healing journey through his own trauma, and his hope was that one day he would get it published and be able to share it with others to help them feel less alone. And today in particular, the really interesting thing to me is he would often talk about this dream that he had, of one day being up on a stage in front of an audience, speaking truth to the trauma that he went through, again with the hope that he would help others find their healing journey and be able to feel less alone. So the irony of me being up here today doesn't escape me. So 9 years ago, almost about a year into our relationship and into our work with each other, he decided to end his life 12 hours before our next appointment. 12 hours. I can't even begin to tell you how long that this number has haunted me. The questions that started to come. Why couldn't he have just held on a little bit longer? Didn't he know that we had an appointment and we could have tried to make it better? And then there was the most painful one. What did I miss? The first lesson that I learned in navigating this tragedy was that time and time again, we will choose pain over losing control. So often when someone dies by suicide, we put all the blame on ourselves. You see, for me, it was easier to accept the blame and responsibility than it was to accept the reality that suicide is made up of so many different factors and isn't attributable to just one thing, or in my case, one person. The pain of blaming myself almost became addictive, as if it was a form of punishment that I was using to inflict upon myself to make up for something that I felt that I had done. To me, it was easier to replay that last moment with him in my head over and over again, searching for something that I missed before I would pass out from sheer emotional and mental exhaustion, than it was to accept the reality that suicide is this complex entity. Because if I accepted that reality, by default, I would have to accept the fact that it wasn't my fault. That there was nothing that I could have done to stop him. And that meant that I wasn't in control. And for anyone who knows me, you know how much I love control. I crave it in my life. If I could find the way to control, I totally would. Because what I realized is that if I'm not in control, there is no way that I can ever prevent this from happening again. And that, to my core, was my deepest fear. How do we even begin to confront the reality that if someone really wants to die, there is nothing that we can do to stop them? You know, in my field as psychologists, we often joke that we have this slight narcissistic tendency, some of us not so slight, where we think that we can save people. And honestly, it's probably part of the reason a lot of us get into this field is because we really feel like we can make a difference and an impact. But for me, what it meant is I had to start to let go of this illusion that I was more powerful than I actually was. That I needed to start to see myself not as superhuman, but as human. So what I learned from this is that holding on to control, despite whatever amount of pain that we have to endure, is actually the thing that keeps us stuck in our healing. I mean, how can you ever expect a wound to heal, right? If you just keep reopening it over and over and over again. What I learned is that actually letting go of control, despite how hard it is, can be one of the most freeing things that we can ever experience. And it can actually signify the start of our healing process. The second lesson that I learned in navigating through this tragedy is that shame is one of the loneliest places a person can ever be. Soon after his death, what I found is that people started to distance themselves from me. They started to tiptoe around me, felt like they saw me as differently, and even at times it almost felt like they were treating me as fragile, like they were waiting for me to break. A lot of times when we need people the most, they avoid us. And it's not that they don't care, it's just that none of us ever really know what to do or what to say to console someone who has lost a person, especially if that loss has been to suicide. And if people distancing from us isn't enough, there's this thing, right, called shame, that quickly becomes this unwelcome visitor in our lives. For me, it felt like I wasn't like other psychologists, and that people could tell this just by looking at me. That somehow his death had left this permanent stain on me that was visible to anyone who dared to even really look. I remember interviewing for my job actually here at the university about 4 months after he died. And toward the interview day, I got asked a question. So tell us something that we wouldn't know by just looking at you. I froze. Is this a trick? Could they see this stain that's all over me, even though I've worked so hard to be able to mask it? I couldn't tell you how I actually answered the question that day, but what I can tell you is that I did not tell them about this. I wasn't ready at that time to break my silence, because I feared that if they knew this about me, I would be seen as deadly in their eyes. You know, so often we create these things in our head, these pieces of shame that grow and grow and grow. Brene Brown, who many of you probably know, talks about if you actually put shame in a petri dish and you add 3 ingredients, silence, secrecy, and judgment, it grows exponentially. And that's what happened to me as mine grew. It felt like every person who was looking at me saw me as having something wrong with her. And the fact that people were avoiding me just served to reinforce this, that there was something wrong with me, and that I, in fact, would never, ever be right again. What I learned through this process was just how much pain suffering alone can create. If I could somehow have my 28-year-old self right in front of me today, right now, I would want her to know there is nothing wrong with her, and that she doesn't have to suffer alone in her grief. I want all of us to know that there is a community of people who have lost folks to suicide, and there are resources to be able to access them. There's even this day called International Survivors of Suicide Day that takes place every November and honors those left behind by suicide deaths. I can't be the person to stand here today and to tell you that after 9 years, I'm completely healed. The reality is that I'm not. I still have my harder moments, and honestly, I don't actually fully believe that someone ever completely heals from a tragedy like this. It's impossible to return to the old version of ourselves when you go through this type of trauma. But what we can do is we can put our energy toward healing. And we can put our energy toward creating the life that we're going to have after this tragedy occurs. So coming up with the ending of this talk was actually the hardest part for me. To try and end a story that had an all too tragic and all too sudden ending just on some level felt wrong. I can't tie it up all nice and neat with a bow. Again, it's just not the reality of it. But at the same time, what I can do is share a couple of things with you. I can share that what I know now is I'm working hard to let go of the need to be able to control the decisions that my clients and others in my life make. What I know now is that I have no stain, and there is nothing wrong with me as a person or as a psychologist. I'm actually pretty amazing. And most importantly, what I know now is that I didn't kill him. The book that he actually wrote sits on my bookshelf in my office, still unfinished. It reminds me that my healing process is also unfinished. And in some way, it feels like it keeps me connected to him and connected to all of us who have gone through this type of pain. I now know that I'm not alone, that none of us are alone. Thank you.
Yes. Thank you. So, I'm not going to go through these slides either, quickly I will go through them, but just to think about how do we restore balance for ourselves, right? How do we find, the mic. How do we find a way to get through this, for lack of better words? I think about my vagus nerve, and that was my little picture to the right, and how I have to always recenter myself in the work that I'm doing, like every day, every session, every supervision, every getting in the car to process through it, to go to the next place, to either do the next job or go home and go inside and do the next job. And so take time for you. Take up space in all you do. And we have to remember this. We have to breathe. I know these are going to be really hard things that I'm about to teach for the next few minutes, right? And how do we do our own breath work? When are we exercising? How are we exercising? If you're exercising in Colorado, you'll get a lot more lung span than anywhere else I've ever been. I thought the Mile High City meant something else. I did not know it was literally a mile high. So yeah, I'm still trying to breathe, in my space. So making sure we do that. What are we putting in our body? Here's all the stuff I'm putting in mine. No, so I'm working on that. I'm not done yet, right? Isn't that what she said? None of us are. So, making sure that you're allowing for enjoyable stuff all the time. Sleep, exercise, movement. We need to get up and move right now, right? I got one more 5-minute video, but we got to get up and move through it. Is everybody ready to do that? All right, awesome. And making sure we get enough sleep and exercise and all those good things as well, right? But this was really interesting to me, and I hope it's beneficial to you.
What if I told you there was something that you can do right now that would have an immediate positive benefit for your brain, including your mood and your focus? And what if I told you that same thing could actually last a long time and protect your brain from different conditions like depression, Alzheimer's disease, or dementia? Would you do it? Yes, I am talking about the powerful effects of physical activity that is simply moving your body, has immediate, long-lasting, and protective benefits for your brain, and that can last for the rest of your life. So what I want to do today is tell you a story about how I used my deep understanding of neuroscience as a professor of neuroscience to essentially do an experiment on myself, in which I discovered the science underlying why exercise is the most transformative thing that you can do for your brain today. Now, as a neuroscientist, I know that our brains, that is the thing in our head right now, that is the most complex structure known to humankind. But it's one thing to talk about the brain, and it's another to see it. So here is a real preserved human brain. And it's going to illustrate two key areas that we're going to talk about today. The first is the prefrontal cortex right behind your forehead, critical for things like decision-making, focus, attention, and your personality. The second key area is located in the temporal lobe, shown right here. You have two temporal lobes in your brain, the right and the left, and deep in the temporal lobe is a key structure critical for your ability to form and retain new long-term memories for facts and events. And that structure is called the hippocampus. So I have always been fascinated with the hippocampus. How could it be that an event that lasts just a moment, say your first kiss, or the moment your first child was born, can form a memory that has changed your brain that lasts an entire lifetime. That's what I want to understand. I wanted to start and record the activity of individual brain cells in the hippocampus as subjects were forming new memories, and essentially try and decode how those brief bursts of electrical activity, which is how neurons communicate with each other, how those brief bursts either allowed us to form a new memory or did not. But a few years ago, I did something very unusual in science. As a full professor of neuroscience, I decided to completely switch my research program because I encountered something that was so amazing with the potential to change so many lives that I had to study it. I discovered and I experienced the brain-changing effects of exercise. And I did it in a completely inadvertent way. I was actually at the height of all the memory work that I was doing. Data was pouring in. I was becoming known in my field for all of this memory work, and it should have been going great. It was, scientifically. But when I stuck my head out of my lab door, I noticed something. I had no social life. I spent too much time listening to those brain cells in a dark room by myself. I didn't move my body at all. I had gained 25 pounds, and actually, it took me many years to realize it, I was actually miserable, and I shouldn't be miserable. And I went on a river rafting trip by myself because I had no social life. And I came back thinking, oh my God, I was the weakest person on that trip, and I came back with a mission. I said, I'm never gonna feel like the weakest person on a river rafting trip again, and that's what made me go to the gym. And I focused my type A personality on going to all the exercise classes at the gym. I tried everything. I went to kickbox, dance, yoga, step class, and at first it was really hard. But what I noticed is that after every sweat-inducing workout that I tried, I had this great mood boost and this great energy boost, and that's what kept me going back to the gym. Well, I started feeling stronger. I started feeling better. I even lost that 25 pounds. And now, fast forward a year and a half into this regular exercise program, and I noticed something that really made me sit up and take notice. I was sitting at my desk writing a research grant, and a thought went through my mind that had never gone through my mind before. And that thought was, gee, grant writing is going well today. And all the scientists always laugh when I say that because grant writing never goes well. It is so hard. You're always pulling your hair out trying to come up with that $1 million winning idea. But I realized that the grant writing was going well because I was able to focus and maintain my attention for longer than I had before. And my long-term memory, what I was studying in my own lab, seemed to be better in me. And that's when I put it together. Maybe all that exercise that I had included and added to my life was changing my brain. Maybe I did an experiment on myself without even knowing it. So as a curious neuroscientist, I went to the literature to see what I could find about what we knew about the effects of exercise on the brain. And what I found was an exciting and a growing literature that was essentially showing everything that I noticed in myself. Better mood, better energy, better memory, better attention. And the more I learned, the more I realized how powerful exercise was, which eventually led me to the big decision to completely shift my research focus. And so now, after several years of really focusing on this question, I've come to the following conclusion: that exercise is the most transformative thing that you can do for your brain today for the following 3 reasons. Number 1, it has immediate effects on your brain. A single workout that you do will immediately increase levels of neurotransmitters like dopamine, serotonin, and noradrenaline. That is going to increase your mood right after that workout, exactly what I was feeling. My lab showed that a single workout can improve your ability to shift and focus attention, and that focus improvement will last for at least 2 hours. And finally, studies have shown that a single workout will improve your reaction times, which basically means that you are going to be faster at catching that cup of Starbucks that falls off the counter, which is very, very important. But these immediate effects are transient. They help you right after. What you have to do is do what I did, that is change your exercise regime, increase your cardiorespiratory function to get the long-lasting effects. And these effects are long-lasting because exercise actually changes the brain's anatomy, physiology, and function. Let's start with my favorite brain area, the hippocampus. The hippocampus, or exercise, actually produces brand new brain cells in the hippocampus that actually increase its volume as well as improve your long-term memory, okay? And that including in you and me. Number two, the most common finding in neuroscience studies looking at the effects of exercise, long-term exercise, is improved attention function dependent on your prefrontal cortex. You not only get better focus and attention, but the volume of the hippocampus increases as well. And finally, you not only get immediate effects of mood with exercise, but those last for a long time, so you get long-lasting increases in those good mood neurotransmitters. But really, the most transformative thing that exercise will do is its protective effects on your brain. Here you can think about the brain like a muscle. The more you're working out, the bigger and stronger your hippocampus and prefrontal cortex gets. Why is that important? Because the prefrontal cortex and the hippocampus are the two areas that are most susceptible to neurodegenerative diseases and normal cognitive decline in aging. So with increased exercise over your lifetime, you're not going to cure dementia or Alzheimer's disease, but what you're going to do is you're going to create the strongest, biggest hippocampus and prefrontal cortex, so it takes longer for these diseases to actually have an effect. You can think of exercise, therefore, as a supercharged 401k for your brain, okay? And it's even better because it's free. So this is the point in the talk where everybody says, that sounds so interesting, Wendy, but I really only want to know one thing, and that is just tell me the minimum amount of exercise I need to get all these changes. And so I'm going to tell you the answer to that question. First, good news, you don't have to become a triathlete to get these effects. The rule of thumb is you want to get 3 to 4 times a week exercise, minimum 30 minutes an exercise session, and you want to get aerobic exercise in. That is, get your heart rate up. And the good news is you don't have to go to the gym to get a very expensive gym membership. Add an extra walk around the block in your power walk. You see stairs? Take stairs. And power vacuuming can be as good as the aerobics class that you were going to take at the gym. So I have gone from memory pioneer to exercise explorer, from going into the innermost workings of the brain to trying to understand how exercise can improve our brain function. And my goal in my lab right now is to go beyond that rule of thumb that I just gave you, 3 to 4 times a week, 30 minutes. I want to understand the optimum exercise prescription for you at your age, at your fitness level, for your genetic background, to maximize the effects of exercise today and also to improve your brain and protect your brain the best for the rest of your life. But it's one thing to talk about exercise, and it's another to do it. So I'm going to invoke my power as a certified exercise instructor to ask you all to stand up. We're going to do just 1 minute of exercise. It's call and response. Just do what I do, say what I say, and make sure you don't punch your neighbor, okay? Music. 5, 6, 7, 8. It's right, left. And I say, I am strong now. Let's hear you.
I am strong now.
Ladies, I am Wonder Woman strong. am inspired now. You say it.
I am inspired now.
Last move. Pull it down. Right and left. Right and left. I say I am on fire now. You say it.
I am on fire now.
And done. Okay, good job. Thank you. I want to leave you with one last thought, and that is bringing exercise in your life will not only give you a happier and more productive life today, but it will protect your brain from incurable diseases, and in this way, it will change the trajectory of your life for the better. Thank you very much.
So yes, just 2 minutes. Did anybody feel worse after they got up and did that? So even a minute or two in a therapy session, a little dance to get back into our body and get out of our mind. I always said social work was the neck, right? We got to pull that together whenever we can. So, thinking about pleasure. When's the last time you felt, I'm sorry, you had a question?
I know, I'm just like asking all questions here.
No, I love it.
I work with a lot of people who are disabled or have mobility issues, and I know exercise is a really good thing, but a lot of times our ways of able-bodied exercise is very different, so I don't know if you have any ideas of how we can increase that client, or if I can't get out there to take a walk.
Yes, I had a client that I worked with for a long time, and it's really laughter. Laughter is medicine, so that's where we started, and we did do some chair stuff with the arms here and there, but we never could get past that because the mobility didn't allow it. But we could watch a show that made us laugh. We could tell jokes in our sessions that made us laugh, and every time they laughed, they felt better. So there are smaller ways to get to increased happiness, and it doesn't always have to be, like a pill that connects that, but how do we connect that through, our own divine intervention? And I always say laughter is definitely medicine. So yes, finding your pleasure somehow, right? And then even our clothing, like not wearing stuffy stuff to work so that we can feel better when we're there, right? Just for the long hours we're going to be there, the things that we're going to be doing. And I know it sounds, odd in some senses, but it's so true to think about those kind of things because we don't. Just even the way the pens feel in our hands, or, me being a lefty, trying to find a notebook that actually works for me. Taking mind inventory, thinking about our intellect and our emotional processes, and accessing our own unconscious or subconscious can be a really powerful thing to do to take care of you. Thinking about our spiritual inventory, like our backgrounds, beliefs, practices, like the things that make us who we are, and how connected are we to them right now? And if we're not connected enough, how do we connect to them in a stronger sense? I have to put community in here because, like I say, if there's anyone in community that's not doing well, then none of us are. So we have to always think about that as we wrap each other in organizations and families and communities. Our environmental inventory, like thinking about Mother Earth, the way I talked about earlier, and just seeing, thinking about a rock. I know this sounds funny, but when I was at American Indian Health and Family Services, I was charged with finding the rocks for the sweat lodge once, and so I was like, oh, okay. Everything is a lesson in the story, though, so I went out to an elder's house, and he started to tell me a story about the rocks, one that I think about a rock when I stubbed my toe, I think about a rock when I was kicking it, I think about a rock sometimes, but definitely not in the context that he brought to me. And so what he said was, each rock that you see on the top of Mother Earth protrudes from the center or core of the earth to present itself to you. And the resilience behind that is really, really powerful. And I was like, wow, I never thought about that. Were any of you in the grief workshop? So the rock, right? It represents a lot in the context of if we hold it, it gets warmer, right? And that's why we can use it for sweat lodge. If we were to even take a rock and have that be like a formative process for our care providers at work to, write down, like she said, either someone's name or remembering someone that left the work. Grief doesn't always have to include death. It can be leaving or, other things attached. So keeping those kind of context in mind. In our wisdom inventory, I always say, the more I know, the less I know, and I say that like through a culturally humble lens. I used to walk around saying I was culturally competent back in the day, and then I realized there's over 200 languages in indigenous populations alone, and so if I don't know all of those, and that's only 5% of the population, I'm not even close. Right? So having humility come along with wisdom. I can't wait. I'm about to be in the elder line like really soon. And that means I get to eat first in my community. So I'm excited about that. Oops. In our creative inventory, sometimes I feel like we leave our creativity at home because we get so overwhelmed with like the paperwork and the to-dos, and so we can be creative in the work that we do, and sometimes it takes a little longer, or we have to call it practice-based evidence instead of evidence-based practice, but we know that's what really works, right? So, advocating for things like that can help us through the day. And loving people, your love inventory, like how we love, who we love, when we love, if we love. Oops. And then our pure being inventory, right? So it's beyond words. It can be defined as our capacity, but, I always call it my circle. And when I work with people, I call it that too, and I put everything inside the circle that I can control, and then leave everything outside of it that I can't, right? So always do things that are productive, right? So I love this little graphic here. So we're practicing the art of being present when we are present. We're respecting and setting boundaries that include ourselves, because we're important and we deserve boundaries and we deserve days off and we deserve those kind of things. And opening your mind to the possibilities of like where we want to go next. Like we should be forward thinking all the time, not thinking about what we've done in the past at organizations, but what can we do in the future that'll make things better. And then delighting in life's little pleasures. So like the ice cream, who didn't go to Haagen-Dazs this week and just kind of walk over and get one? Well, I wish you would have. But anyway, oh, you did, good. See, so we have to take those life's little pleasures and do things for us and then uplift someone else. I love to go in the grocery store and just tell an elder or a woman, you look beautiful today, or, you look handsome today, or you look really good today, and just share that with someone for no reason at all. I'll never forget, my partner gets so mad at me, like, do you have to social work the world? Everywhere you go? And so we were in Myers, and of course that's a grocery store in Michigan, and the lines were off the chain. And the first time I was social working the cashier, though, that we went, right? And that's when she was yelling at me saying, why do you have to do that? Why do you have to, sit there and give her therapy too? Can't you just, do your job and be off when you're off? And I'm like, well, it's like passion is part of me. It's not really a job. It's like who I am, right? So I shared with that person and helped them, and we come back to the grocery store. Now it's Saturday, and the lines are really off the chain. And so we go to get in one of those long lines, and I see that same cashier, and she says, oh, come here, I'll take you before I go to lunch. And so we get up in the line, and we go through really quickly, and we get out in the car, and I said, see, karma is a mother. So it can make a difference, right, in what we emanate and the energy we put out. I always tell everybody, don't read any more evidence-based practice, read The Secret. It's a book about emanating what you want in this world and saying it until you get it. I won't read the rest of these to you, but I will say, like I said, there's a lot of different toolkits that I've provided here to help service provision, and has training videos and, all the good things here. And so also my contact information's at the end. If anyone wanted to reach out and talk with me more, know that I'm available that way as well. Thank you so much.
Thank you so much, Bridie. I'm going to get us set up for the last section of our time together today. Let's pause though and see if anyone has any questions or anything you want to reflect back about what we've covered so far. Could I hand the microphone over to one of you all? Thank you.
Yes. Mm-hmm. Great question. So, question from Oregon about mandated reporting. They don't have it. That's awesome. I can speak to California. In California, mandated reporting is a requirement for certain licensed providers of various care. So for mental health, for physical health, teachers, and I think law enforcement are also considered mandated reporters to themselves, which is kind of funny. But what happens next is basically I get to keep working. If I don't report what's mandated to report and somebody dies, then I lose my license to practice. Unless it shows that I did my due diligence in other ways and maybe didn't know that that was going to happen. But there's a real a legal pressure to break confidentiality in times when someone's life may be at risk. And it also, like here we're talking about suicide, that's one thing around mandated reporting. The other things that are mandated to report are around child endangerment, elder abuse, and some licenses have to report domestic violence. Mine doesn't, but medical providers do. So, yeah, great question. And I'm glad to hear that it's not the same everywhere. Yeah.
Who do you report suicide, ideation, or attempts to?
I'm required to report it to law enforcement. And part of that is because in the county that I work in, law enforcement are the ones who can make the determination to remove the civil rights. Lawanda was talking about how where she works, a clinical social worker like myself could decide that. And so in that setting, it might be different, but I can't. And where I work, there isn't, in the county where I work, law enforcement, hospital staff, or county behavioral health employees are the three entities that can remove civil rights for protection. And the area where I work, the only folks that are there are law enforcement. We're in a more rural area of Sonoma County, and some of our folks live 2 hours down a mountain road to town, and so it's primarily law enforcement for me. Yeah. Thank you, in Chicago. And so there are training resources for de-escalation in the United States. I know I went through a training through the Crisis Prevention Institute, which is in California. You did too, and you're not in California, so that's great for access.
It's international,
It's
CPI.
international, okay. And so don't feel limited by the resources that someone hands to you. Because of the ruralness of our area, we also are like, who brought you to this appointment today? Your grandma? Do you trust your grandma? Okay, great. Grandma, come in. Grandma, can you get this person a ride to safety? Great. I didn't have to call the police. Right. Because I could document that there was safety. I'm so sad about
I would
say
say safety plans are for staff. That's why we upload them. Care plans help people.
Yeah,
feel
safety
cared
plans
for.
aren't even really for us. They're for
Whoever in the EHR.
yeah.
Thank you so much. We'll have some more time for questions at the very end, but for our last section of the session, I'm going to build on what Jen and Lynea and Lawanda and Bridie have already talked about to look at some of the collective practices that can be helpful in supporting the whole people and the whole communities involved in this work. And then specifically talk about ways of holding space for different emotions that might include grief or remembrance, and any responses that come up when we lose someone to suicide or another cause. So one framework that might be helpful is healing-centered engagement. This is a framework developed by Dr. Sean Ginwright in 2018. It was originally created for work with BIPOC youth, but it's since been expanded to other groups and applied more widely. Healing-centered engagement builds on trauma-informed care, and it shifts the focus from trauma to healing, from the individual to the collective, towards shared strengths and culture and civic action and community. And it really expands the thinking from what happened to you that we ask from a trauma-informed perspective to what's right with you, and promotes agency over collective well-being. So I'll go over some examples of what healing-centered engagement might look like and some ways that we can apply it in our teams and in our organizations. So this might look like, in your organization, things like circle processes. I've heard reference to healing circles that different organizations are using as part of how they respond after an emotionally impactful event. Promoting diversity, equity, and inclusion, certainly throughout all of your work, not just on written policies. Valuing lived experience and having that be part of how you're approaching all of the work you're doing. Looking for creative ways to support your staff, maybe what time off looks like, different models that really are serving the individuals that you work with and what their specific needs might be. Creating spaces for healing, we're going to go into that in a little more depth in just a minute. And then creating that psychological space, that safety, to truly speak up about what the challenges are, and then have a place to talk about how to address them. Some of the specific practices that might include are regular ways that your team is connecting. Could mean a morning meeting and an afternoon meeting together, if that is a rhythm that works for you. But whatever the time frame is, there's some time when you all are able to touch base, share information that's helpful to you, vent, just let things out that have come up during your day. Shared caseload models and team approaches and cross-training. This allows people to step away, to take time off without feeling that they're leaving the folks that they're working with no one to connect to in their absence. Training and continuing education, opportunities to continue to pursue your individual interests, and any skills, if there are things that you're feeling insecure about, those are often the things that are keeping us up at night, that are leading to burnout, when we don't feel confident in our skills. Sabbaticals, time away, community gatherings, staff work groups. That's a fantastic way to address challenges, that if people feel safe enough to bring up things that are problematic, then having staff work together to find solutions. mindfulness practice, collective action. This, as we've talked throughout the morning, much of what we see show up on the individual level reflects systematic and structural oppression and pain, and finding ways for us as our providers and the communities we work in to be involved in work to challenge those systems can be a really important part of the healing process as well. Reflective practices in groups. And then this trauma-informed communication. As Lawanda talked about, how do we share the news of when we've lost one that we care about? Is there a perspective and approach that we take there and considerations to help do that in a way that's trauma-informed for the folks who are going to be receiving that news? So while taking time off or practicing individual self-care can be important, the people we work with might be the only ones who truly understand how we're feeling after a patient or a client has died. We may be able to share memories with them or talk through things that are coming up for us in a way that we are not necessarily able to with other loved ones in our lives who don't know the person or don't really understand the specifics of what our work is like. So having spaces together to share our different emotions, to honor the life that's been lost, can be really essential. A few of the ways that I've heard talked about in this conference and from others that different teams have found to create space for each other are grief circles. I actually heard Dr. Desani in the opening keynote talk about how the Peach team in Toronto gathers together, lights a candle, has time to talk about the person they've lost, reflect on their experiences, caring for that person, and pausing for silence and reverence. Lynea, you told me about your rose garden at Shore Health Center. Would you mind telling a little bit about that?
Yeah, so we, like probably many of us, didn't have a real great structure around grief, and people kept dying because that's the work that we do in healthcare anyway, even if you're not adding in the compounding elements of homelessness and all the factors that go along with that. And so one of our doctors and his buddies just showed up with rose plants and planted roses all around the perimeter of the main healthcare for the homeless building, and was able to get little year plaques. And the community is aware, and we're aware that these roses are in honor of all the lives lost. And the community members come and tend to the roses. We tend to the roses. There isn't a formal yard person for our roses. It's more of a collective project to have an ongoing honoring and to show that our folks who are still living, that we're caring for, that they matter even after they die, and that helps in their healing process as well. And then helps us to have an outlet too, because this is such a frequent experience that we needed something that sort of managing, like closing clinic every time something terrible happens, and then also honoring our own humanity and collective need for connection around this. Yeah.
Thank you. My colleague Courtney, who works at a health center in Portland, Maine, was telling about her team's practice where they have a paper tree on the wall and paper leaves, and anytime they lose a client, they write a name, the person's name on the leaf, and put it on the wall, and then at their monthly meeting, they read all the names. And when they feel they're ready, they take leaves off and put them in a box that's always kept, but they're giving themselves whatever time it takes to see those names up there. And there's no timeline for grief, as we know. There's also Homeless Persons Memorial Day, which is December 21st, the longest night of the year. That's sort of a common time that our whole community, I think most cities do something in observance of that day, whether it's a gathering where you read the names of all lives lost in your community during that year. But connecting with things like that are other options for ways to make space. So our primary goal for this morning, which has gone so quickly, was that you would leave with some specific ideas to take back with you. So we're going to spend our last few minutes to take time to reflect on what you want to focus on. We'll use those key takeaway and next steps worksheets that are on your table. I invite you to spend a few minutes thinking about what you want to prioritize as you get back to your community. And then spend a couple minutes talking to a neighbor and just sharing what you've written and what you're hoping to focus on. We'll do that for 5 minutes and then come back together for any final questions or comments before we say goodbye for today. Thank you all. Thank you, Bridie, Lynea, Jen, Lawanda, so much. Thank you all for being here and for the ways you've contributed today. There is a paper evaluation on your table, and we would love to get your feedback to help us plan future sessions. So if you don't mind taking a minute just to fill that out, it's more complete than the evaluation in the app. You can leave it on the table, and we will pick it up afterwards. If you want to take any of the coloring books or colored pencils, fidget items with you on the table, take them, please. And thanks again.